wasting time, would like to invite our next chairpersons. May I have the honor to request Dr. Amren Kumar Singh sir, Consultant Gastroenterology, Patna, ex-head of the department, IGMS. May I have also the honor of inviting Dr. V.K. Dixit sir. I also invite Dr. Gyanendu, Consultant Gastroenterology, Patna. And lastly, I would like to invite Shailesh Kumar Singh, Consultant Gastroenterology at Patna. We will start the next session, which is a part of luminal gastroenterology. And the first talk will be by Dr. G.K. Dali sir of PGIM and R Research, Kolkata. And the topic is abdominal tuberculosis and audit from the IPG, ME and R. So may I have the honor to request Dr. Dali sir to kindly start with this.
Side effects are well known, but it is well known. Having said that, you have to keep an eye of the common side effects that the patient have because of ATD. I think I am able to finish it well in advance, and I would like to thank for your kind attention. And I'm sure that you have a lot of questions, and let's see whether I can clarify any of them. Thank you.
So thank you so much, sir, for your insight on this topic. We kindly request you to be seated on the dais.
Moving on, may I have the honor to invite our second speaker of the session, Dr. Professor V.M. Dayal sir, to please come on the stage. With over 3 decades of experience, he is the professor and head of department in gastroenterology, IGMS Patna. His skills and expertise lies in gastroenterology, stents, liver diseases, hepatocellular carcinoma, liver cirrhosis, gastrointestinal and pancreatic diseases. His topic for today is an update on current treatment strategies in IBD.
Good audience even after lunch, that includes the speakers, and I will be talking about the treatment of IBD, but because of the shortage of time, I will only be dealing with the mainstream treatment. I will not talk about treatment of complications or other situations. And to begin, so inflammatory bowel disease or IBD, as you know, is a chronic immune-mediated inflammation of the GI tract, often with a progressive and destructive course. And the two major diseases that we challenge with are Crohn's disease and ulcerative colitis. So, when you get a patient who seems that he may be suffering from IBD, then the first thing to know is to decide is whether it is CD or UC. Then you want to know the extent of the disease. Then especially for CD, because the disease behavior is a very important prognostic factor. So you want to know what kind of disease behavior is expected or seen previously, and then the severity of the disease. Of course, there's no single test or a gold standard which will make the diagnosis. So you have to use the whole compendium of the history, the clinical examination, family history, and diagnostic testing to arrive at a diagnosis, and then determine the appropriate treatment. So when the patient comes for the first time, this is the algorithm which has been proposed, that you do the labs, you can do the stool studies because calprotectin has been associated with inflammation in the gut. And then, depending on the patient's presentation, you can proceed to ileocolonoscopy most of the time, or if it's ulcerative colitis, you can make a diagnosis only with flexible sigmoidoscopy at the first instance. And based on those, and if there are upper GI symptoms and if suspected Crohn's disease, then of course an upper GI endoscopy is indicated. Based on the biopsy reports, you could diagnose as normal or Crohn's disease or ulcerative colitis. Ulcerative colitis being more straightforward to diagnose because it is localized mostly to one organ, and it's a mucosal disease, so you get those histological findings more easily. Otherwise, if you're still suspecting Crohn's disease, then you have to go for imaging with CT or MR enterography, which will delineate those parts of the gut which are affected. And you can also, if that is also non-contributory, then capsule endoscopy can pick up sometimes those difficult to treat Crohn's disease. What are the clinical features which would suggest, or what is, how do you differentiate whether you're primarily dealing with UC or CD? So ulcerative colitis will involve only colon, rectum, and Crohn's, any part of the GI tract. In ulcerative colitis, the disease starts from the rectum and spreads proximally. So rectum is almost invariably involved, whereas rectal involvement is less common in Crohn's disease. Then disease in ulcerative colitis is mucosa and submucosal inflammation, except when it becomes complicated. And Crohn's disease is typically transmural, and that leads to many strictures, fistulae, and perineal involvement. Ulcerative colitis, the involvement is usually in a continuous fashion, from where it starts to where it ends, and then there's a good cut off into normal mucosa. Then you will get scup lesions in Crohn's disease. And it is acute onset most of the time, and Crohn's disease may not be so presenting with an acute flare, though sometimes it may. Then you know all these, because it's a chronic disease, you get rectal bleeding, frequent small volume fluid, tenesmus, mucus discharge, abdominal pain. And this is how it looks on a colonoscopy, and this is the histology. The most prominent feature being the distortion in the crypt architecture with crypt dropout, crypt shortfall, a mixed inflammatory infiltrate, and mostly very few or no granules. Then there's a score which we use to score the endoscopic activity, and this is very important because only then you can object it, because mucosal bleeding, as you know, is becoming the focus of attention nowadays. Previously we used to treat the patient based on the symptomatic relief, but now it has been found that those patients who have mucosal relief, they have better long-term outcome, less chance of relapse. So it is important to be able to quantify the amount of mucosal disease and the relief provided as a treatment or the resolution of the lesions. In Crohn's disease, which can affect any part of the gut, you have symptoms depending on the site of involvement. Predominant site of involvement, like small bowel, will present with abdominal pain, diarrhea, maybe fever. Only may have bleeding along with diarrhea and weight loss. If there's stricture, you will get features of bowel obstruction. Then you can get abscess or fistulae. And as you can see in the chart, ileocolite is the most common type, which is about 50%, and the rest would be in the colon, small intestine alone, or rectum. Again, picture showing the kind of ulcers you see. There are deeper ulcers in Crohn's disease, and they are frequent in the ileum as well. And this is a lesion detected on capsule endoscopy, ulcer in the small bowel. And the histology would show transmural inflammation, which all layers of the gut are inflamed, infiltrated with inflammatory cells, as well as the presence of granulomas. Again, there was endoscopic COT score for Crohn's disease as well, on the size of the ulcers, and the percentage of the arterial surface, and the presence of stenosis. Now coming to treatment part, we have to determine several characteristics related to the disease and other comorbidities besides the plan of action. We have to characterize the disease activity, the severity, whether there are any complications, what was the response to prior treatment, there's any associated infection or other comorbidities. So how do we determine disease activities? Disease activity is based on patient-reported outcomes. So we have got the Harvey Bradshaw score for CD, the simple clinical colitis activity for UC, in which the patient symptoms are quantified into a score. Another way to determine disease activity is the inflammatory burden based on extent of disease and severity, and you can test for markers like fecal calprotectin, CSR or CRP. And then disease severity, of course, depends on the phenotype that this particular patient has and depends on several factors. So this is a simple clinical colitis activity index. There are other scoring systems also which are equally good, in which you can score how active the disease is, and you can follow up the progress by determining whether the score is coming down. Similarly, in CD, you have the Harvey Bradshaw activity index, which has the parameters of the well-being of the patient, presence or absence of abdominal pain, the number of liquid or soft stools, whether there's a mass or any complications. Then it is important to determine the extent of the disease. For that, you have the Montreal classification. When ulcerative colitis, ulcerative proctitis is T1, left-sided colitis is T2, and pancolitis is T3. Similarly, for Crohn's disease, age at diagnosis A1 below 60, A2 between 17 and 40, A3 above 40. The location of the disease, L1 for ileal, L2 colonel, L3 ileocolonal, and L4 isolated upper disease, and L4 can be added to the predominant site of disease to complete the diagnosis required. And the behavior, whether it is non-strictural, non-penetrating, then it's B1, it's the most benign form. Then B2 is strictural, B3 is penetrating, and P if the patient has got perineal disease as well, then you can add that as a modifier. So what are the risk factors in a particular patient which will make you alert that this patient could have a more severe course, more difficult to treat, and poorer prognosis? For ulcerative colitis, if the age is younger, less than 40, whereas in Crohn's, even less than 30 is considered more severe. If there is extensive involvement, like pancolitis is more severe than proctitis, obviously. And in Crohn's disease, there are multiple areas of the gut which are involved. And what is the score? Mayo score or UCI's score? In Crohn's disease, perineal or severe rectal disease also indicates severe involvement. So if the patient requires hospitalization, that means acute severe ulcerative colitis. If there are deep ulcers in Crohn's disease, elevated CRP and lower albumin in ulcerative colitis, and Crohn's disease patient has got history of prior surgical resection or the history of stricturing or fissuring, that would indicate more severe disease. Then coming to biologics in IBD, which are or biologic agents or novel small molecules. So when we should consider using these agents. So if the investigator is not working, whether it is mesalamine or steroids or therapies, then definitely biologics should be considered. If the patient is dependent on glucocorticoid, that means he cannot taper off from steroids. If you taper, the disease relapses. These are candidates for biologics. Again, not responding to therapines and methotrexate. Severe Crohn's disease with fistulas and extraintestinal medication is also an indication. And it includes severe ulcerative colitis refractory to steroids. There is a definite role for biologics, especially infliximab, which has been shown to be equivalent to cyclosporine in some trials. So these are the common indications in which one should consider use of biologics. And all the same goals of people with the same induction of remission, phase prevention, healing the fistula, minimizing complication surgery, quality of life, minimizing adverse events. This is to show the various classes of compounds, infliximab, anti-TNF, trastuzumab, Kaival's drug. Infliximab and adalimumab are available here. Then you've got IL-12 and 23 E40 agonists, not available as yet. IL-23 19 antagonists, also not available. Then you've got alpha 4 beta 7 integrin antagonist and vedolizumab is available. And the others are not. Yes. How do you predict which patient is going to respond? So there are predictors of good response, there are predictors of poor response. If there is a significant short-term CRP drop, that inflammation is settling. Paradoxically, extensive colitis at baseline is a predictor of a good response. If you are using immunosuppressive agents like calcium immunomodulators, then if you use them together, again, alkene naive, they have not been exposed to alkenes, then they are likely to respond. And if the tough level is good, then the response is good, and there are some related factors. And poor responses at the same time, they are not responding. And especially patients who have already been treated with IV corticosteroids or have been exposed to IV cyclosporine, they are likely to respond poorly. Then there are methods in which you can optimize the response. When you're using anti-TNF agents, you can optimize the response. It has been shown that if you use these agents early rather than later, then the response is better. Studies show that treatment before 2 years has better long-term remission rate than if you treat after 5 years of the disease. And this is also exemplified in the better response in pediatric age group to these agents. Then a big problem with anti-TNF is the presence of antibodies to the agent, and which results in kind of leading away of the response. In this situation, concomitant with an immunomodulator like IL-12 definitely helps because it prevents the formation of antibodies, reduces the current, and maintains the response. So several studies have shown, there was a REACT trial which showed that the need for surgery, need for hospital admission, and the complications. The lesser if the group combined anti-TNF with diapirins than anti-TNF. And then you can use the drug and antibody levels to make therapeutic decisions and to optimize the response. For example, if the patient has shown initial response, not responding now, then you get an antibody level. If the antibody level is low, that means the drug is not giving sufficient amount to the affected areas. Then shortening the frequency or increasing the dose will help. On the other hand, if the antibody levels are high and the patient is not responding, then obviously this patient is not going to respond. Then you can try another class of compound. What about adverse effects? There are plenty of adverse effects, but not seriously. There are serious adverse effects, but you have to be careful about them, including tuberculosis, fungal infections. Then there are certain infusion reactions that you want to tackle with, especially infliximab. You get dermatologic and neurological manifestations. There is a increase of melanoma or lymphoma. And as we talked about antibody formation, there's lots of them. Then another class of compounds is the anti-IL-12 and 23p40 antagonists, ustekinumab. And this has been approved for both CD and UC by the FDA in US. And it is useful both for induction as well as the maintenance of remission. Higher remission rates we see in bio-naive rather than bio-exposed. Adverse events include headache, nausea, paresthesia, and fatigue reactions. This drug was originally licensed in psoriasis. So there is a key solar safety data in which there was found there was no increase in risk of cancer, major adverse cardiovascular events, or serious infection out there. So all in all, it seems to be a safer molecule. Unfortunately, not available to us. Then you've got anti-integrin compounds, natalizumab and vedolizumab. Natalizumab is a monoclonal antibody against alpha-4 beta-1 and alpha-4 beta-7 beta-3. And it's been licensed for using tonsils, not used for ulcerative colitis, both for induction and maintenance of remission. It has got an unusual complication of progressive multifocal leukonephria because of JC virus deactivation. As a result of this, you have to test for JC virus before you start the therapy, then follow up, you have to keep testing. So overall, it just put this drug into the back burner kind of. Then you have vedolizumab, which are only antibodies against alpha-4 beams, which are 7 integrin, and this molecule is not present in the brain. So theoretically also has less very low risk of PML. And it has got a relative all selectivity. So I'll take 2 minutes more. So one of the safest I think in the current law, because less chances of infection and malignancy. But it is more useful in UC than in CD. Then another drug which is available to us is the common inhibitor, ifazimib. It is an oral JAK1 and JAK3, little less on JAK2 inhibitor. It's improved for ulcerative colitis, not effective in Crohn's disease. There are certain issues with this drug as well, which is oral drug, very useful drug. But Professor Zoster is a problem with elevation of lipoproteins, it could be deranged liver enzyme. And the FDA has got a black box warning because increased risk of myocardial infarction, stroke, thromboembolic death. So in those patients with high risk, probably it's not a good idea to use. But carefully it can still be useful. And of course non-melanoma skin cancer is also being seen with this agent. Then SIP, S1P inhibitors, ozanimod is an oral drug against rimocin 1 phosphoreceptor subtype 1 and 5 antagonist. It has been approved for induction and maintenance in ulcerative colitis. And again, there's some cardiac complications. So the patient has got heart block or severe liver disease. It is better not to use in those patients.
Audience program is Dr. Gaspar.
Then coming to mucosal healing, as I talked, like previously used to depend on symptomatic relief, but now we're focusing on mucosal healing because number one, symptoms do not correlate with mucosal inflammation. So the disease is still active, the patient is feeling better. Then you have to assess whether actually the patient inflammation is still flared before you think of changing the drug. And as I said, now in the latest trials, mucosal healing is considered one of the major endpoints because likelihood of flare decreases, correlation to disease complication decreases, need for surgery and hospitalization decreases. So we should focus on mucosal healing. I'll skip all this because I think you know all this. Something about steroids. because this is the most commonly used drug. So there are 3 or 4 important points that I want to make regarding the use. First of all, use the effective dose, 40 to 60 milligram, because many times we feel going to the lower dose and it doesn't work, it leads to prolongation of steroid use. And our aim should be use steroid for the minimum time possible. Then do not overdose. If the dose is not working, adequate dose is not working, and switch to IV formulation or switch to a different agent. There is no point in increasing the dose of the oral drug. Then the focus should be on shortening the treatment and steroid period treatment as far as possible. Then you anticipate side effects. In appropriate patient, you can switch to budesonide because it has got a better safety profile. And those patients who are steroid dependent or need more than two or more doses a year, or who have needed parenteral steroid admission, they are candidates for immunomodulator or biologics. So these points should be kept in mind while they use the steroids. Okay, since I'm out of time, I'll skip all this. Thank you.
Thank you, sir, for your insights on this. We request our chairpersons on the dais to set about the discussions.
large cap TB and some institute treating as a IBD.
Yeah, this is a very pertinent question, but I would be, or the gastroenterologist must more frequently confuse Crohn's disease with industrial tuberculosis. Industrial tuberculosis is very easy to differentiate industrial tuberculosis from Crohn's disease because, as Professor Dayal said, that in ulcerative colitis, the disease is a continuous disease, and the disease is limited to the mucosa and submucosa. On the other hand, you have tuberculosis is predominantly involved the ileocecal region. Your rectum is spared. So that is one of the most important issue. And then in TB there will be transmural involvement. So in ulcerative colitis it is never transmural, it is mucosa and submucosa. So these two are the main features, and then will come the histology. In histology, the ulcerative colitis will show the mucodepletion, there will be cryptitis, crypt abscess, there will be branching of the mucosa. On the other hand, in tuberculosis, you get a granuloma, confluent granuloma, or facial necrosis, then it is diagnosis of tuberculosis.
You said it's absolutely right, but you are also right. We have 2 published cases of tuberculosis presenting as acute ulcerative colitis. Throughout was well, only the biopsy showed us granulomatosis 47, and then we treated for ATD and reticulum. Both are published in endoscopy.
Dr. Singh, as I understand, you said that rectum tuberculosis is not present, but I have seen few cases of rectal tuberculosis. So, in fact, I believe no organ in the body is spared by tuberculosis. Of course, it is rare, but personally, I have seen tongue, mouth, esophageal, duodenal, including rectum.
Yes, you are right, sir. Tuberculosis can involve any part of the GI tract or any part of the abdomen. So any intra-abdominal chronic condition need to exclude tuberculosis.
In tuberculosis, I think surgeons never do a diagnostic lab, so you have to do it.
Thank you.
Stop this.
Perspectives on the topics. We would like to request our chairpersons sitting on the dais to present the memento of appreciation to our speakers. We also request our we would request all to please join join in for a short photography session. So please. Everyone for your honorable presence. With this, we mark the submission of our third session of luminal related conditions.
Moving on to our next session, which is related to pancreatobiliary conditions. We would like to invite our distinguished chairpersons to have their seat upon the dais. Dr. Sandeep Nejuan, he is the Senior Professor, Head of Department of Gastroenterology at SMS Jaipur. Dr. Manoj Kumar is Senior Professor and Head of Department of Surgery at AIIMS Patna. Dr. Ramesh Kumar is Additional Professor in Department of Gastroenterology at AIIMS Patna. Dr. Priya Ranjan is Senior Consultant Gastroenterologist in Patna. Dr. Ravi Khan is an Associate Professor in Department of Gastroenterology at IJMS Patna.
May I kindly request our acclaimed speaker of the session, Dr. S.P. Mishra, to come up on the dais. Dr. Sri Prakash Mishra is a Senior Professor and a pioneer of Department of Gastroenterology and Hepatology at Motilal Nehru Medical College, Prayagraj. He has over 230 publications and over 5,000 citations. His skills and expertise lies in liver cirrhosis, gastrointestinal diseases, esophageal diseases, pancreatic diseases. His topic of discussion for today is strength, weakness, opportunities and threats, an analysis of medical profession. I kindly request him to begin with his speech.
विजय शंकर जी कहाँ हैं? भाई पहले ही चीज तो टाइम के लिए आपको बता दिया था मैंने. कुछ करना पीछे नीचे ढकेल देना, लेकिन वो स्लाइड मत दिखाना कि वो टाइम इज अप. दो हार्ट बीट छूट जाला हमारा. लगता बस यमराजे बोल रहा है. अभी आप लोग, मैं सारी भाषाएं मिला के बोलूँगा, अंगिका उनका सब बदला के बोलूँगा, हिंदी अंग्रेजी सब इंग्लिश में बोलूँगा. सबके लिए ये केवल हम लोग के लिए, सबके लिए. Normally what happens is SWOT analysis done for industries and for technocrats. But we should also do a SWOT analysis for medical profession. And what I'll be telling you, you'll not find in any textbook, anywhere in the internet. This is just out of sheer experience. बाल सफेद होने के बाद ही समझ में आता है. ये बेटा चल नहीं रहा. मेरे पास 3 लेक्चर थे. मैंने पूछा क्या सुनना चाहेंगे आप, तो ये सुनना चाहिए. बहुत मीठा नहीं है, कुछ मीठा है, कुछ कड़वा है. कड़वा ज़्यादा है, लेकिन समझना पड़ेगा. ये सच है. रियलिस्टिक होना, ऑप्टिमिस्टिक होना, पेसिमिस्टिक होना, तीनों अलग अलग चीज़ें. यू हैव टू बी रियलिस्टिक. आवर प्रोफेशन इज गोइंग थ्रू अ वेरी रफ पैच. जितने रेगुलेशन हम लोगों के हैं, उतने रेगुलेशन किसी टेररिस्ट के लिए भी नहीं होता. आप उठा के देख लीजिए, कहीं जाना हो आपको दिक्कत है. और रोज के रोज नए रेगुलेशन आ जाते हैं. कंपनी वाले आपको ये नहीं कर सकते, आप वो नहीं कर सकते. नीचे से लेकर ऊपर तक, पहले तो आपका सीनियर, फिर HOD, फिर डायरेक्टर, फिर डिप्टी सेक्रेटरी, जॉइंट सेक्रेटरी, सेक्रेटरी, मिनिस्टर, चीफ मिनिस्टर, जिसको देखो प्रताड़ित करता है. और जो आता है वो जाके धमका जाता है, क्योंकि आपके पास पावर नहीं है, रिटेलिएट नहीं कर सकते. देश में अनफॉर्चुनेटली जंगल राज है. सच पूछिए, पावर से डरते हैं. एक पुलिस वाले से डरेंगे, इनकम टैक्स वाले से डरेंगे, जजेस से डरेंगे, लेकिन आप हाईली क्वालिफाइड होने के बाद डर क्या होना नहीं चाहिए. इज्जत होनी चाहिए. वो खत्म हुई. कुछ हमारी भी गलतियां हैं. सो आई बीन इन द इंडियन सोसाइटी ऑफ गैस्ट्रोएंटरोलॉजी फॉर डॉग नंबर ऑफ इयर्स. ये तो बहुत पुराना है, 15 साल से कहीं ज़्यादा है. काउंसिल मेंबर, सेक्रेटरी जनरल फॉर 8 years, एंड प्रेसिडेंट इलेक्ट, प्रेसिडेंट पास्ट, प्रेसिडेंट एडवाइजर, ऑल दोस थिंग्स. We have 2 training programs in gastroenterology. अभी नेजाउन सबसे बात हो रही थी. YCP होने वाला है, GYM होने वाला है. We train about 150 DMB students. उनसे पूछो, जब मैं इंट्रोडक्शन में लेता था हर साल, तो पूछो कि क्या एम है, तो बस एंडोस्कोपी सीखना साहब, पैसे कमाना. उनकी गलती नहीं साहब, सोसाइटी ऐसी हो गई. पहले गांव में किसकी इज्जत होती थी? सब लोग, आप लोग गाँव रूरल बैकग्राउंड से होंगे, एक डॉक्टर की, एक मास्टर की. अब तो प्रधान की इज्जत होती है, वो करेक्टर सर्टिफिकेट लिखता है. तो जब आप यही कर लोगे तो होगा क्या मिलेगा. So there is a great expectation versus increasing expectation. The society has changed for the worse. एम फैक्टर अब एम से कुछ भी लगा लीजिए, मसल, मनी, माफिया, आगे बहुत कुछ है जो लिख सकते हैं। हमारे यहाँ 2 और एम है, मुलायम और मायावती। वी हैव बिकम मटेरियलिस्टिक, हम लोग भी और सोसाइटी भी। अगर आपका बड़ी गाड़ी खड़ी हो तो आप खड़े डॉक्टर हैं। मैं आपको एक छोटा वाक्य बताता हूँ। तो मेडिकल कॉलेज में था, मैंने डिपार्टमेंट ऑफ गैस्ट्रोएंटरोलॉजी डॉक्टर मनीषा के साथ इस्टेब्लिश किया। 9 साल हो गए थे, मेरे पास गाड़ी नहीं थी। माँ बाप कहती है बहुत खुश, लेकिन मैंने लिया नहीं था, स्कूटर चलता था। तो मैं एक लेक्चर देने एक बहुत बढ़िया टॉप रेस्टोरेंट इलाहाबाद गया, तो जो कंपनी वाले थे कहते हैं अबे लगा थे इनका प्रैक्टिस चलत नहीं ना। उस समय मेरी फीस 300 रुपये थी, जब हेड ऑफ डिपार्टमेंट मेडिसिन की फीस 30 रुपये थी। ही आस्क्ड मी, कह रही यार तुम 300 लेते हो, हम 30 लेते, तो मैंने 30 कर दिया अपने कहने से। और भीड़ लगी रहती थी, लेकिन ठीक है, ये अप्रीहेंशन है। स्कूटर पे चलोगे तो भाई कुछ नहीं है, लिमोजिन में चलोगे तो बहुत बड़े डॉक्टर, चाहे भले वो चोरी चमारी से आया हो, कोई बात नहीं। रिलेशंस ऑफ पेशेंट्स विद पेशेंट्स हैव चेंज। हमारा रिलेशन पेशेंट से और पेशेंट का चेंज हो गया। कंज्यूमर प्रोटेक्शन एक्ट एंड मेनी मोर थिंग्स आर टू बी ब्लेम्ड फॉर इट। सोसाइटी बेसिकली हो गई। भगवान मानते हैं आपको, जब वो भगवान मानता है, कहाँ मानता है? जब मेडिकल कॉलेज अकेला होता था, कोई नर्सिंग होम नहीं होता था, तो मैंने देखा वो फेस। जब भगवान मानता था, आपके पीछे आगे पीछे हाथ पैर जोड़ कर सब भर्ती कर लिए किस तरह मेडिकल कॉलेज में। अब जगह जगह नर्सिंग होम हो गए, कौन पूछता है मेडिकल कॉलेज में? सरकार भी ऐसी हो गई जो कुछ नहीं, और मेडिकल कॉलेज की हालत खराब हो गई। नर्सिंग होम बेटर है, फैसिलिटीज तो बेटर है। फैसिलिटीज बेटर मतलब नहीं समझी, स्लीवलेस लड़की या फिर सबसे तो मिल जाएगी वहाँ पे, बाकी जो होगा सो होगा, लेकिन ये सफाई थोड़ी ज़्यादा है। सब रिस्पॉन्सिबल हम लोग भी रिस्पॉन्सिबल है इसके लिए। गूगल बाबा आ गए, हर आदमी गूगल करके आता है, गूगल बाबा सब कुछ बता देते हैं, अनसॉलिसिटेड एडवाइस आता है। और एक टेंडेंसी अब देखा मैंने इधर हो गई है, मरीज को जब आपके पास नहीं आना होगा ना, तो 2 सवाल आपसे पूछता है, डॉक्टर साहब कब तक इलाज चलेगा, और डॉक्टर साहब क्या हुआ है। वो 12 फॉलोअप के बाद पूछेगा डॉक्टर साहब क्या, उसका मतलब वो अब नहीं आने वाला आपके पास, चट गया है। चलिए कोई बात। एक और चीज हो गई कि आपके पास अगर मरीज आ गया तो मरना नहीं चाहिए, मरेगा तो हम आपको मार देंगे। भाई सबको मरना है। अभी भी मरीज हमसे पूछते हैं, जब आई एम वेरी फ्रैंक, हम बिल्कुल बकायदा आदमी भाई, चाहे जो आप बुरा माने भला माने, मैं अपनी इज्जत पे कॉम्प्रोमाइज करके प्रैक्टिस नहीं करता हूँ। दबंग हूँ, साफ साफ बात करता हूँ। वो यही पूछेगा साहब वो गए थे, दवा का साइड इफेक्ट हो गया इसलिए हो रहा है। तो तुम्हें पता है दवा का साइड इफेक्ट हो गया क्या? लेकिन वो दवा ब्लेम करेगा। मैंने कहा दवा नहीं थी तो लोग नहीं मरते नहीं थे। मेरे परदादा और दादा जो बिना दवा के जो मर गए वो सब बेकार थे। ऑल डेथ्स आर बिकॉज ऑफ डॉक्टर्स, ये परसेप्शन हो गया। हम लोग यमराज के एजेंट बन गए, और विजय शंकर जी जरूर बन गए, वो स्लाइड दिखा देते। So what is the difference between a good endoscopist, good doctor and a great doctor? No doubt endoscopy is exciting आज भी and paying, and that is what separates an internist from you. That is what my mentor Professor B.S. Anand told me when I joined GB Pant way back in '86. But is endoscopy all or something else? What makes a good doctor and what makes him great? अब ये प्रॉब्लम हमारी डॉक्टर सबकी शुरू होती है MBBS से. To be a good doctor, at least 1 million facts should be remembered at a given time. 10 लाख फैक्ट्स याद होने चाहिए. यार 2 गर्लफ्रेंड का नाम तो याद ही नहीं रहता, 10 लाख फैक्ट कहाँ से याद है? बट द ह्यूमन ब्रेन का ओनली रिटेन 1% ऑफ इट. 1% से ज़्यादा रिटेन नहीं कर सकते. आप बिलीव करिए, ये स्लाइड में आपको दिखा रहा हूँ, 10 सेकंड बाद आप इस स्लाइड को भूल जाएंगे. रिटेंशन इज ओनली 10 seconds. Being a good doctor is not easy today. There's too much of work. अभी मंडल साहब से बात हो रही थी, भागते हुए चले आके फिर उनको बोलना है कि आपको सुनना है, झूठ है, हमको सुने थोड़ी, हमारा लेक्चर नहीं आए. लेकिन उसमें लगे क्या थे, उसमें ये कर रहे वो कर रहे, ये बन गए वो बन गए, भागे जा रहे हैं. उनके चैम्बर में तो नहीं थे वहाँ पे, खाना खाए कि नहीं खाए ये भी नहीं पता. There's too much of work. लोग कम है, काम ज़्यादा है. There's too much of hassle. There's too much of paperwork. This is bad. हम लोग टेक्नोक्रेट्स हैं, हम लोग को पेपर वर्क बिल्कुल नहीं होना चाहिए. हमने मुंह से कह दिया बहुत है, अब हर चीज डॉक्यूमेंट करिए, ये होना चाहिए, ऐसे होना चाहिए, ऐसे लिखना चाहिए, ये लिखना चाहिए, ये जेनरिक. अबे जेनरिक बोलते हो, बैन कर दो ना बाकी दवाओं को. क्यों नहीं? हमारे हाथ में थोड़ी है, तुम्हारे हाथ में. आप केवल जेनरिक बनाइए. कंपनी वालों से आप बैकडोर से पैसा लें, आपको कहेंगे हमको कहेंगे जेनरिक लिखिए. कहाँ से जेनरिक लिखिए? केवल आप जेनरिक बनाइए ना. किसने मना किया कि DDR लिखिए? बोलिए साहब, इसको लिखो। पेशेंट्स आर अनहैप्पी, दे आर नेवर हैप्पी। ऐसा नहीं कि सब अनहैप्पी है, कुछ है 10-20% है जो बहुत खुश हैं, बहुत आपकी इज्जत करते हैं। देयर इज टू मच ऑफ कंपटीशन। और अब क्या हो गया साहब, अब तो 3.5 लाख 5 लाख लोग निकलेंगे, और आयुष को भी डाल दिया उसी के अंदर। अब नर्सेज भी आ जाएंगे, वार्ड बॉय और स्वीपर भी आ जाएंगे जो आपसे कम्पीट करेंगे। पहले हम लोग अस्पताल बनाते थे, उसमें कंपाउंडर रखते थे, अब कंपाउंडर अस्पताल बनता है, उसमें डॉक्टर रखता है। ये चेंज आ गया है। There's too much of despair. बहुत खराब लगता है, डिप्रेशन बहुत ज्यादा है, एंजाइटी बहुत ज्यादा है डॉक्टर्स में, एंड there's too little reimbursement. राजस्थान में तो सर आपके यहाँ गवर्नमेंट कैप कर देती है, कितने पैसे ज्यादा नहीं सकते। सही बात है ना, बताइए। आपका मोल कोई और लगा रहा है, आप स्लेव की तरह हो गए, ये इससे ज्यादा नहीं ले सकते। किसी वकील का तो नहीं किया होगा साहब, हर ही साल में तो 2 मिनट बात करने के 5 लाख रुपए लेते थे 20 साल पहले। गमले में लोग 11 करोड़ की गोभी उगा लेते हैं। So what qualities makes up a good doctor? It's about brain or skill, or about compassion and empathy? I think it's both. आपके पास ब्रेन भी होना चाहिए। एक चीज हम मानते हैं, पक्का मानते हैं, मैं बचपन से ये कहता हूँ और बराबर कहता हूँ, सब बच्चों से कहता हूँ, सबसे ज्यादा इंटेलिजेंट कोई होगा तो सब आप लोग बैठे हैं सर सामने। अपने लिए ताली बजा लीजिए। We are the most intelligent people on earth. और सबसे ज्यादा कंपैशन एम्पैथी भी होती है। आज भी कोई मरीज गड़बड़ होगा तो आप रात भर जग जाओगे उसके लिए। ये कोई और प्रोफेशन में नहीं है, किसी प्रोफेशन में नहीं, केवल आपके प्रोफेशन। ये आपकी स्ट्रेंथ है 1 to 1। लेकिन उसके बावजूद हम लोग इंटेलेक्चुअल नहीं माने जाते हैं। आप एक मीटिंग बताइए जो आपके चीफ मिनिस्टर ने बुलाया इंटेलेक्चुअल्स में, डॉक्टर्स को बुलाया गया। मेडिकल में भी क्या, आपने कोविड में देखा डॉक्टर कहाँ थे, कहीं नाराज। वो बताते आपको ये करना है। जर्नलिस्ट इंटेलेक्चुअल हो जाएगा, लॉयर हो जाएगा, जजेस तो ही है इंटेलेक्चुअल, उनको सब कुछ आता है। सूरज के नीचे जो भी कुछ सब आता है। पॉलिटिशियन हो जाएंगे, लेकिन डॉक्टर चाहे जितना पढ़ा लिखा हो, जितनी डिग्री हमारी देखी आपने, इंटेलेक्चुअल से हम लोग नहीं मान रहे। उसका कारण हम खुद हैं। कुछ लोग तो दिन भर प्रैक्टिस करते हैं, हम जब बहुत कम करते हैं, लेकिन वो शाम का समय जो सोशलाइज करने का होता है, उस समय ज्यादा तो लोग लिपस्टिक पाउडर लगा के बैठ जाता है, क्लाइंट आएगा। तो हमारा जो सोशलाइज करने का समय वो प्रैक्टिस का समय है, इसलिए हम आप किसी से मिलते नहीं। देखिए आप जहां मिलेंगे, हम लोग डॉक्टर्स आपस में बहुत अच्छे से मिलेंगे, लेकिन बाकी समाज से मिलने के समय क्या हो, 6 से 9, 10, उस समय हम लोग बिजी रहते हैं। तो ये बहुत बड़ा फ्लॉ है हम लोगों में। जब तक हम समाज में जाके नहीं मिलेंगे, nobody is going to care for you, and that is why all relation come against you. लॉयर्स के खिलाफ क्यों नहीं आता? एक तो मिलिटेंट है वो लोग, और दूसरे उनके क्लाउड। You need to wear many hats. You have to be a clinician, academician, manager. You have to be a CEO. You have to be a financial expert, self-caretaker. But याद रखिएगा, after all, you are a husband, wife, son, daughter, father, mother, brother, sister, and have social responsibility जो मैंने आपको बताया। और सबसे जरूरी आपकी अपनी जिंदगी है। शायद आपको ये पता नहीं हो कि विजय शंकर दिखाए ना दिखाए वो स्लाइड, हमारी मोर्टेलिटी आम आदमी से ज़्यादा है, डिप्रेशन ज़्यादा है, फ्रस्ट्रेशन ज़्यादा है, बर्नआउट ज़्यादा है। वो दूसरा लेक्चर है मेरा। यू हैव टू हैव अ सेंस ऑफ रिस्पॉन्सिबिलिटी विद डेडिकेशन। खुद ही कोई देख ना रहा हो तो भी आपको अपने ईमानदारी से काम करना है। यू हैव टू हैव कंपैशन एंड एम्पैथी। बेसिकली यही है, इट्स एन आर्ट। जो पहले मानते थे आर्ट है भाई, बहुत हमारे जो टीचर थे वो मेडिकली बहुत साउंड नहीं थे, लेकिन वो आर्ट था उनका। बात करने की भी आर्ट थी और प्रैक्टिस की भी आर्ट थी। इट्स एन आर्ट एंड दिस इज यू हैव टू हार्प ऑन एवरीबॉडी एल्स कि हम भगवान नहीं है भाई। जजेस और जो साइंस, परफेक्ट साइंस है, आपको मानते हैं कि ये नहीं हुआ तो आपकी गलती, आप जेल जाओ या इतना कंपेंसेशन नहीं साहब। आर्ट है, एक दवा किसी के ऊपर जहर है, किसी के अमृत है, किसी के लिए। ये समझता ही नहीं कोई, समाज में नहीं समझता है। वो सोचता है कि आपके पास सब कुछ, आप भगवान है। वही मैंने सुबह कहा था, अगर आपका पैर कोई छूटा था नीचे, उससे बच के रहिए, खतरनाक है वो। अरे डॉक्टर साहब आप तो भगवान है। भगवान नहीं है भाई। हमने डॉक्टरी पढ़ी, हम डॉक्टर बन गए, आपने वकालत पढ़ी, आप वकील बन गए। दूसरी सबसे इंपॉर्टेंट चीज जो हम आपको एक बार कहना चाहते हैं, एक बात याद है, लॉ हमको पता होना चाहिए। कानून ना पता होने का हम बेवकूफ बनते हैं। मुझे कानून पूरा पता, मेरे घर में सुप्रीम कोर्ट में जजेस हैं, हाई कोर्ट में चीफ जस्टिस हैं, जिंदगी भर लॉ देखा, मुझे पूरी लॉ पता है। आई नो मोर लॉ देन ए लॉयर और ए जज। So nobody can take me for granted. Be it criminal, be it civil. हम लोग लॉ से नहीं जानते, थोड़ी थोड़ी बात पे ही ना चिंता करने लगते हैं, ये क्या होगा, ये क्या होगा. एंड ट्रस्ट मी, आपके जितने अच्छे दोस्त होंगे लॉयर या जजेस, काम पढ़ने पे कोई काम नहीं आता. हाई कोर्ट में वकाल वगैरह साहब, वो तो पास ओवर कर तो दूसरे जज के सामने, क्योंकि मैं इनको जानता हूँ, ये हो जाता है. The patient does not care how much you know until he knows how much you care. यहाँ पे भी प्रॉब्लम हमारी है, इतनी भीड़ है कि you cannot show him that you care. बट इतना एक्सपीरियंस हो जाता है कि कुछ मरीजों को कुछ ज़्यादा समय चाहिए, उनको ज़्यादा कंपैशन चाहिए. हम लोग छूते नहीं हैं. हमको बड़े बड़े अस्पताल, नाम नहीं लूँगा, दिल्ली के बड़े बड़े अस्पताल से मरीज आए हैं जो कहते हैं डॉक्टर्स की मदद. हमने तो अपने डॉक्टर को देखा ही नहीं, किसी ने मुझको छुआ ही नहीं. छूना बहुत ज़रूरी है. अछूत नहीं है मरीज आपका, अब तो अछूत की बात ही खत्म हो गई. छूना बहुत जरूरी है, झुकना जरूरी है, स्माइल करना जरूरी है. लेकिन कब तक स्माइल, जितना स्माइल करोगे 100 मरीज देखते राइसेस ऑटोमेटिकस हो जाएगा. तो प्रॉब्लम हमारी भी है, लेकिन आप अपनी कम करिए, नहीं करिए तो अच्छे से करिए. रेजिडेंट्स लर्न बैड मैनर्स बिकॉज ऑफ द ह्यूज वर्कलोड. वो भी परेशान है, खास करके बड़े बड़े अस्पतालों में जहाँ DNB शुरू हो गया, सुबह से शाम तक दौड़ते रहते हैं बेचारे. You need to learn to hold the patient during his entire journey. You have to be professional, and professional incompetence is the greatest sin. आपका professionally आपको एकदम competent होना पड़ेगा. Money is a big taboo and I'm very bad at it. I squandered all my money. कोई बात नहीं, बड़ी बात नहीं है, उससे कुछ अंतर नहीं पड़ता. You have to learn to be cost effective. Instead of increasing the cost, कम cost में volume बढ़ाइए. Volume ज़्यादा हो, cost कम हो, तब succeed करेंगे. ये हो गया ना कहीं? मैंने आपको पहले ही कहा था. अरे यार 2 हार्ट बीट खत्म होगी तो मजाक कर रहा हूँ. You have to be a font of knowledge. मैंने बोला professional incompetence is the greatest sin. I just rushed through. You have to have humility. Arrogance नहीं होना चाहिए. और arrogance कहाँ होता है? अरे उसको दिखाया था, उसको कुछ आता है. ये नहीं होना चाहिए कभी, क्योंकि कोई आपके लिए भी कहेगा ठीक है, I'm at the pinnacle, हमको कोई चैलेंज नहीं कर सकता है, मरीज भी जानता है, लेकिन ठीक है, उसके बावजूद भगवान भी तो ऐसा नहीं करना चाहिए. ठीक. You have to upright behavior to consider the arrogance. Don't care. Don't give in to unreasonable demands of the patient. Patient हो या कोई हो, जो unreasonable demand उसको बिल्कुल मत करिए. Just for the sake of money, don't get bullied. You're open to medical errors and misdiagnosis. Unfortunately, एक चीज मैं हर जगह कह रहा हूँ जो कोई नहीं सुन रहा है, हमारे लिए एथिक्स है, मरीज के लिए एथिक्स क्यों नहीं भाई? उसके भी तो एथिक्स होने चाहिए. वो जैसे चाहे वैसे बात करे, दवा खाए ना खाए, दिखाए ना दिखाए, फॉलो अप आए ना, जो मर्जी वो कर ले, उसके लिए सब माफ, 7 खून माफ. तो हमारी एथिक्स का, हमारी एथिक्स भी नहीं रहेगी फिर तो. केवल डॉक्टर्स के लिए एथिक्स होती है, पेशेंट्स के लिए भी एथिक्स हो सकती है. इट्स अ टू वे, 2 हाथ से ताली बज रही है. हमको तो आपने जकड़ के रख दिया, मरीज के लिए भी एथिक्स होना चाहिए. Recognize just the strength but also your weakness. Then we are not God. That is important. So again, medical science is an art which is developed over years of experience. हमारे रेजिडेंट थे हम लोग, तो सारे मरीज लगते थे. अब पता 200 मरीजों में इन 4 को हमको देखना है, बाकी को उतना टाइम नहीं देना है. कम्युनिकेशन स्किल एंड बेड साइड में ये कहीं पढ़ाया नहीं जाता है. अब सुना मैंने, मेरी वाइफ MCI में इन्वॉल्व है, तो अब सुना मैंने कि ये करिकुलम में आ गया है, लेकिन इसको पढ़ाया नहीं जा सकता. इसको आपके टीचर से सीखना पड़ता है. हमारे टीचर बड़े एथिकल थे, काफ़ी कुछ सीखा हम लोगों ने. वी आर बैड टीचर्स, आई एग्री ऑन दैट. सो देयर इज अ नॉन वर्बल कम्युनिकेशन, सॉफ्टन इसका एक्रोनिम है. स्माइल, मुस्कुराते रहिए जब तक राइसेस और डॉटिकस ना हो जाए. वी हैव टू हैव एन ओपन पोस्चर, फॉरवर्ड लीन, मरीज को झुक के, जैसे वेटर होता है ना, झुकिए थोड़ा सामने. टच इज वेरी इंपॉर्टेंट. आई कॉन्टैक्ट इज वेरी इंपॉर्टेंट. हमसे तो इंटरव्यू में भी लोग डरते हैं, जो एग्जाम नहीं लेते, तो आंख में आंख मिला के नीचे करके, तो मैं बोलूँगा नहीं देखिए, हम तो देखिए, तो आंख मिलाना जरूरी है. एंड अ नॉड. बनारस से BHU से कहाँ गए सब लोग हैं यहाँ पे, वाजपेयी साहब थे, वो देखते थे डायबिटीज के मरीज, डॉक्टर साहब थोड़ा मीठा खा ले, ठीक है ठीक है, थोड़ा सा खा. मे बी वेरी, मतलब मेडिसिन की चीज़ नहीं है, लेकिन वो जो जेस्चर था उनका, वो उनकी प्रैक्टिस बहुत हाई स्किल पे. ठीक है ठीक है, ये उनका पेट वर्ड है, ठीक है ठीक है, कोई बात. हम लोग नहीं करते हैं. इट बिकम मोर डॉगमेटिक. Expectations from doctors, you have to be confident, empathic, humane, personal, forthright, respectable and thorough. अब ये तो भगवान भी ऐसा नहीं है, हम कहाँ से हो सकते हैं। अब अपने बारे में अपने ब्रैग नहीं कर रहा हूँ मैं, ढेर सारे पब्लिकेशन है, 5 इनवाइटेड एडिटोरियल्स हैं, एक जीआई एंडोस्कोपी में, 2 एंडोस्कोपी में, एक गट में और एक जर्नल ऑफ गैस्ट्रोएंटरोलॉजी हेपेटोलॉजी में। एंडोस्कोपी में जो है उसमें रविकांत कहाँ गया? रविकांत इज ऑल्सो एन ऑथर एंड ग्रेटिस नहीं दिया था, इसने मेहनत की थी इसलिए दिया था उसको, एंड इट डिजर्व इट। तो इनका ये गिनीज बुक में नाम है इनका, कोई पेपर नहीं था लेकिन एडिटोरियल था। पहला पेपर जो था वो एडिटोरियल, इनका एंडोस्कोपी यूरोपियन सोसाइटी ऑफ गैस्ट्रोएंटरोलॉजी की जर्नल है। कंग्रेचुलेशन रविकांत। I'm on editorial board of many journals, 14 journals. I'm fellow of all the academies and all those जो भी blah blah blah. ये हमारा गट में एडिटोरियल था, ये जीआई एंडोस्कोपी में था, ये रविकांत का इसमें नाम है, देखिए सेकंड ऑथर। लेकिन क्या हो गया, आप नोबेल प्राइज ही मिल गई। अच्छा एक चीज कोई बता सकता है, यहाँ बैठे बड़े इंटेलिजेंट, मैंने कहा ना नोबेल प्राइज मेडिसिन में किसको मिला दोस्त, कोई बता सकता है? एनीबडी? बीसी रॉय? बीसी रॉय नोबेल प्राइज में, बीसी रॉय अवार्ड होता था, खत्म हो गया, वो भी खत्म हो गया। एनीबडी हु नोस इस साल का नोबेल प्राइज किसको मिला? सारे पैसे पॉकेट में, 1 लाख से कम नहीं लेके चलते, दे देंगे आपको, 2000 की नोट चला लीजिएगा। नहीं पता ना, नहीं पता होना चाहिए आपको। हु केयर्स किसको क्या मिला दोस्त। लेकिन अगर आपके बेटे बेटी को 100 बुखार भी हुआ तो अभी आप परेशान होंगे। इसका मतलब है आपकी पर्सनल लाइफ इज मच मोर इंपॉर्टेंट देन प्रोफेशनल लाइफ और एनीथिंग एल्स। अगर आपकी बेटी की शादी हो गई, वहां उसके ससुराल में प्रॉब्लम हो, तो आप अभी यहाँ बैठे बैठे भी परेशान हो गए। ये इंपॉर्टेंट है। मैंने डिपार्टमेंट बनाने के लिए 24-24 घंटे काम किया, मैंने अपने बच्चों को निगलेक्ट किया, सब पूरे परिवार को निगलेक्ट किया। आई एम गिल्टी ऑफ दैट। यंगस्टर्स के लिए दोस्त, बच्चे जब छोटे उनको कंधे पे उठाओ, घोड़ा बनो, खेलो। अब तो मेरी उम्र आ गई उनके कंधे पे शमशान जाने की, अब उनको कंधे पे नहीं, हमसे लंबे चौड़े हो गए। उसको मत छोड़ना, घूमो। कब घूमोगे? अब मैं जाऊं गुरु डुंगमा और लेके जाना चाहूँ 17,000 फीट पे नहीं जा सकता, मैं पहले हो आया, मेरा टांग नहीं जा पाई, सांस फूलेगी। घूमने की उम्र ये है आपकी, 40, 45, 50 तक जितना घूम सकते हो घूमो, पैसा बाद में आ जाएगा। लेकिन होता क्या, उस समय होता है ये कमा ले, ये कमा ले, ये कमा ले, ये कमा ले, और घूमना छूट जाता, उसके बाद घूम नहीं सकते। 17,000 फीट पे आधे लोग, यहाँ से 90% लोग नहीं जा पाए। तो मैंने क्या किया, पहले मैं रणजी ट्रॉफी खेलता था, वो खत्म हो गया। मेडिकल कॉलेज में आने के बाद शिकायत कर दी लोगों ने, बोला प्रोफेसर ने फेल कर दूंगा। फेल क्या करें, टॉप किया था लेकिन फेल जमगी थी। फादर आए, डांट लगा के गए, झापड़ तो नहीं पड़ा, लेकिन हम लोग को झापड़ पड़ता है, उससे मानेंगे आप लोग। आप बच्चों को नहीं मार सकते। बहुत रोए, कुछ नहीं कर सकते थे, खेलते रहते थे उसके बाद भी। तो इधर मैंने कुछ साल पहले जब डिपार्टमेंट बन गया, सब कुछ हो गया, तो मैंने अपनी ज़िंदगी थोड़ी बदली और थोड़ा संदीप भाई से थोड़ा सा आई बोरोड समथिंग फ्रॉम हिम, और मैं शेर व शायरी करता हूँ, मुशायरे में जाता हूँ, उर्दू लिखता हूँ, हिंदी लिखता हूँ, लिरिक्स लिखता हूँ गाने के। रोज़ एक आध गाने के, पुराने गाने के लिरिक्स ज़रूर लिखूँगा, उसके बिना मैं सोऊंगा नहीं। म्यूज़िक क्लब मैंने 15 सिटीज़ में बनाई, अब करीब 30 सिटीज़ में हो गई है, पुराना साइड है ये। और ये मेरे है भी, मैं 4 दिन पहले दिल्ली में शो किया था, और 15 अगस्त को हेमंत कुमार माले का नाम, अगर आप म्यूजिक में इंटरेस्टेड हो, सबसे बड़ा ऑर्गेनाइजर, ही कॉल्ड मी ऑन फोन, और उसने हमको 6 गाने दिए अपने शो में गाने के लिए। 15 अगस्त। यू नीड 3 P's इन लाइफ। अपार्ट फ्रॉम एज जब बढ़ जाती है, वो पी मतलब पेशाब शुशु करने वाला पी, जो मेल्स के लिए तो प्रोस्टेट बढ़ ही जाता है। यू नीड 3 P's इन लाइफ। यू नीड पैल्स, पेट्स एंड अ पैशन। अगर आपके पास दोस्त हैं, और दोस्त भी याद रखो दोस्त अभी से, अगर आपका कोई ग्रुप है तो दोस्त बनाओ आप 10-10 साल के कोहॉर्ट पे। मैं 70 का हूँ, मेरे दोस्त 70 के हैं, मैं बीमार, मुझे लकवा मारा तो उनको भी लकवा मारो, मदद करने कैसे आएगा मेरी? अरे हंस क्यों रहे यार, मेरी बीबी बूढ़ी तो उसकी बीबी भी बूढ़ी। तो 10 साल का अगर होगा तो आपको जो यंगस्टर्स होंगे वो आपकी मदद कर सकते हैं। और ट्रस्ट मी, जो ग्रुप बनते हैं, म्यूजिक ग्रुप हो, डांस ग्रुप हो, ये उसकी बॉन्डिंग बड़ी जबरदस्त हो। हमने जो ये ग्रुप बनाया था, डॉक्टर चौबल का नाम सुना होगा आपने। चौबल एक आईएसजी मैपिंग है सर, जयपुर में था। ही वॉज गोइंग बैक, उसको चेयर करना था किसी में, बोले नहीं सर मेरी म्यूजिक किटी है सर, जो बनाया था आपने, मैं जा रहा हूँ। मैंने कहा सलूट टू यू। ये पैशन होना चाहिए। कोई चीज़ छोड़ के चला गया वहाँ। अभी परसों बात हुई उन लोगों से मेरी, 1 बजे रात तक गा रहे थे लोग वहाँ पे भोपाल में। तो दैट पैशन, चाहे कुछ होना हो उसको नहीं छोड़ना है। आप जो कर, मैं नहीं कर गाना गाइए, मेरा शौक है, ये लिखता हूँ, ये डांस करिए, गार्डनिंग करिए, कुछ ना कुछ एक्स्ट्रा करिए जो करे, दूसरों की मदद करिए। ये सब मेरे कुत्ते हैं, 7 कुत्ते हैं, अब तो इनमें से कुछ रहे नहीं, ये पेनी है इधर जो दिखने मेरी गोद में। इससे बढ़िया ना मैंने ह्यूमन देखा ना कोई जानवर देखा। एक मेरी गाय थी जो 2 पैर पे मेरे ऊपर खड़ी हो जाती थी, और एक ये मेरा रॉटवाइलर। लोग कहते हैं रॉटवाइलर बहुत खतरनाक है, जिसने सुना हो उसके रोंगटे खड़े हो गए। ये इतना प्यार करता है, कल मैं आ रहा था, ये वॉज क्राइंग, और मैं केवल इसी की वजह से आज वापस जा रहा हूँ। आई डोंट वॉन्ट हिम टू मिस मी। जंगल जाने का बड़ा शौक है मुझको, जंगल और पहाड़, 2 चीज। अब अभी बोलिए, 2 बजे रात को बोलिए, मैं तुरंत चल दूंगा जंगल। ये गोडी है, ये टडोबा है, ये ब्लैक पैंथर है। ये अगले दिन इसको मॉल कर दिया था, राइट। अभी ब्लैक पैंथर और 2 आ गए हैं सब जगह। ये मेरा ब्लैक पैंथर रॉटवाइलर है मेरा, जो मेरे कमरे में रहता है मेरे साथ। ये मुंशियारी है। अभी आप लोग उत्तराखंड जाएं तो मुंशियारी ज़रूर जाइए, अगर सिक्किम जाइए तो गुरुडुंगौर ज़रूर जाइए। ट्रैवल बफ हूँ मैं, कहीं मुझसे एक बार फ़ोन कर लीजिए, पूछ लीजिए कहाँ जाना, और कहीं मत जाइए। आप यहाँ जाइए, उमथाल जाना, यहाँ जाइए नाथुला पास जाना, कुछ नहीं देख, आप जाइए गुरुडुंगौर जाइए, स्वर्ग से अच्छा है। और कभी इसको छोड़िएगा नहीं साहब, यंगस्टर्स जरूर चले जाना दोस्त। दूसरे बी चाइल्ड लाइक नॉट चाइल्डिश। ये दिस इज इन कश्मीर एट द इंडो पाक बॉर्डर। मुझसे कहा साहब वो देखिए रेंजर्स बैठे वहाँ पे, वो गोली मारते वहाँ जाओ। मैंने कहा साले मार दे तो मार दे, मैं जाऊँगा जरूर। ये अफरवट है। जस्ट अ फ्यू लोग, सब लोग जा करके बड़े बड़े 5 स्टार 7 स्टार में एंजॉय कर रहे थे, हम सीधे वहाँ चले गए। हम भी एंजॉय किए, बाद में आ गए, उतना कम किया, लेकिन यहाँ घूमा वो नहीं घूम पाए। प्लान करना बहुत जरूरी है। किताबें हैं मेरी, लिरिक्स ऑफ गोल्डन एरा बताया आपको, लिखता हूँ मैं रोज। एक किताब है, चाहे कोई मुझे जंगली कहे, माई जंगल बुक, द लाइफ लेसन्स आई हैव लर्नड फ्रॉम द जंगल। जंगल से सिखाया मुझको। एक छोटा उदाहरण आपको देता हूँ। बांधवगढ़ गया था मैं, वहाँ जब सुबह सुबह जीप पे जाते तो एक जगह देखा मैंने कि बांस जल गया है। मैंने कहा रुको कि बांस जल गया, बोला नहीं साहब बांस जला नहीं है, देखिए नीचे अंकुर निकले हैं। जब ये 20 साल बाद ये अंकुर निकलते हैं, और 20 साल बाद जब ये अंकुर निकलते हैं तो ये बांस अपने आप मर जाता है। क्या सिखाया उसने? आपके बच्चे हो गए, बड़े हो गए, जाओ, तुम्हारी जरूरत नहीं नीचे। 37 साल उम्र थी आज़ादी के समय हम लोग की एवरेज। बच्चे पैदा हुए, जिम्नोस्पर्म गया इधर से उधर। देखिए आप, टेस्टिस आधा डिग्री नीचे अलग से रहता है, ओवरीज पीछे रहती, ट्रक चढ़ जाए ओवरी नहीं चिपेगी, गुठली खा जाएगी, निकल जाएगी पॉटी में आपके, कड़वा लगेगा आपको मुंह में खाते हुए, लेकिन गुठली गलेगी नहीं। तो जिम्नोस्पर्म को नेचर प्रिजर्व करता है, ये याद रखिएगा। विद ड्यू अपॉलजीज फ्रॉम द लेडीज ओवर हियर, मैडम ही और कोई कहे नहीं। लेडीज खूबसूरत होती है कि आदमी खूबसूरत होता है? आदमी क्यों? छक्का मारना तो बहुत आसान है। इसलिए कि आप नेचर में कहीं भी देख लीजिए, मोर, मोरनी, शेर, शेरनी, चिड़ा, चिड़िया, एनी स्पीशीज देखिए आप, इट इज द मेल बिकॉज इट हैज टू अट्रैक्ट द फीमेल फॉर अगेन फॉर द प्रोजेनी टू कंटिन्यू। वो नेचर है। अब दूसरे अगर होते तो हम लोग रूस पाउडर न लगाते क्या? आजकल हम लोग भी लगाते हैं। Then the lectures of quality of life of doctors, which is very important. आपको अगर बुलाया आपने कभी और देंगे। 10 commandments में लेके आया था, लेकिन उन्होंने कहा आप ये दे दीजिए। Let live another live। और फिर एक और है, bending forwards is easy but don't bend backwards। हम लोग बहुत ज़्यादा सबको तेल लगाते रहते हैं। Trust me, 100 में 1 काम आएगा, 99 काम नहीं आते। ये मेरे जंगल बुक का है, ये सब। ये पीछे मुड़ के देख रहा, 65 साल पे हर आदमी पीछे मुड़ के देखता है एक बार, आदमी औरत, और उसको लगता है यार जिंदगी तो व्यर्थ चली गई। एंजॉय करिए डे 1 से, ताकि ये ना कहना पड़े। आज मुझको अगर यमराज आ जाए तो मैं हाथ पकड़ के चल दूँ आगे कि चलो भाई, आई हैव लिव्ड माय लाइफ। देयर आर मेनी पीपल हु आर हियर, जामन इज वन ऑफ देम whom I know have enjoyed life. There is a passion called life, वो बहुत इंपॉर्टेंट है। मेडिसिन इज अ प्रोफेशन, बहुत लोगों के लिए पैशन भी है, और कड़कते नोटों की खुशबू बहुत बड़ा पैशन है। Your life is much more important. Everyone is dead in the long run. लाइफ इज क्रूअल, वेरी क्रूअल। 5 पुश पहले के अपने फोर फादर कोई नाम बता सकता है यहाँ पे? वो ना होते तो आज आप ना होते, आपके बाप ना होते, आप ना होते, लेकिन नाम नहीं याद है दोस्त। अगला जो बच्चे 2 जन्म आए तो बोले बाबा जी का नाम पूछा, आपका नाम पूछें, मोबाइल में देख के बताएंगे, नहीं याद रहेगा। ऐसा नेहरू की देखा आपने, नेहरू बाग 14 नंबर करते हैं लोग, कभी देखिए जरा, जब वो लोग करते हैं उस दिन सब कौवे की बीट साफ की जाती है और सब माला पहना जाता है। और जो माला पहना था कैसे बना था? ऐसे। वो अपनी फोटो खिंचाने में इंटरेस्ट है, नेहरू जी के नहीं। तो ये लाइफ इज वेरी क्रूअल। पर बताया था मैंने आपको, YCP और GYM में जो जाते थे वो सब लोग ये आई वॉज डूइंग, मैं खेलता था, मैं पिक्चर देखता था, मैं कविता लिखता था। अबे अब क्यों नहीं लिखते हो भाई? किसने मना किया? काम बहुत, अरे काम तो हर समय बहुत रहेगा। मनी इज नेवर टू मच। इफ यू आर द रैट रेस ऑफ मेकिंग मनी, इवन इफ यू विन द रेस, यू आर ब्लडी रैट, क्योंकि रैट रेस है। कहाँ कंपीट करोगे यार? अंबानी एक तिमाही में 12,000 करोड़ रुपए वाइट में बना रहा है। क्या विशाल, हर IAS के पास 1,000, 2,000, 5,000, 10,000 करोड़ रुपए है। हमारे आती माफिया जब सुना सबने होगा आपने, 56,000 करोड़ रुपए की बात हो रही। सोच सकते हैं हम लोग 56,000 करोड़ रुपए कहाँ बैठे हो भाई? कहाँ? तो समझो आपकी अपनी जिंदगी है, पैसा सब कुछ नहीं है। फैमिली इज ऑफ अटमोस्ट इंपॉर्टेंट। फैमिली को कभी निगलेक्ट नहीं करना चाहिए, क्योंकि वो समय निकल गया ना, जिंदगी के सफर में गुजर जाते हैं जो मकाम, वो फिर नहीं आते। Children will grow up in no time. Play with them, travel with them. Money can come later. So आपको शॉर्ट में आपको स्ट्रेंथ बताया मैंने। Your training is the most rigorous. Your core competence is impeccable. You save lives. Now technology, artificial intelligence, machine learning are coming to help you. Don't perceive them as threat. Weakness is lack of communication. We are not considered intellectual. केकड़ा मेंटालिटी है, एक आगे बढ़े तो खींच दो नीचे, चलता है एटीट्यूड। अपग्रेडेशन नहीं करते हम लोग, जो पढ़ लिया सो पढ़ लिया। इन रोम डू एज रोमन्स डू, ये कहावत याद रखिएगा। इंडिया में आपको इंडियन की तरह बिहेव करना, जो अंग्रेजी वाले बताए गए ना वो किताबें जो है, उससे अगर करेंगे तो बराबर गलत होंगे आप। अपॉर्चुनिटीज आर इमेंस। टेक्नोलॉजी एडवांसमेंट, मेडिकल कॉलेज बहुत खुल रहे हैं। COVID-19 वॉज एन अपॉर्चुनिटी फॉर ऑल ऑफ अस। ओनली इन क्राइसिस यू बिकम इम्पॉर्टेंट। एंड थ्रेट आर इमेंस। गवर्नमेंट, लॉज, कोर्ट, सोसाइटीज, टू लॉन्ग अ कोर्स, बॉन्ड आ गया है। मेरे एक लड़का DM करके आया है, 3 साल वो MD के बाद बॉन्ड किया, 2 साल कर रहा है, 5 साल में बुढ़ा हो जाएगा बाद में। ऐसे ही 33, 35, 34 पे हम लोग निकलते हैं पढ़ करके, DM MCH करके, अब 40 पे निकलेंगे। पता नहीं उसके बाद जिंदगी कितनी बची है, कौन जानता है। लेकिन सरकार नहीं समझती, किसी ने ऑब्जेक्ट नहीं किया। 3 साल MD के बाद और 2 साल DM के बाद 5 साल अगर आप उसको चढ़ा दोगे वहां पे, तो क्या करेगा प्रैक्टिस जाकर? Shrinking opportunities, lack of excellent hospital and salary, और थोड़े दिनों बाद तो हम लोग सब कॉर्पोरेट के गुलाम हो जाएंगे। सारे कॉर्पोरेट वाले ले लेंगे, गुलाम हो जाएंगे। और कॉर्पोरेट के नहीं है तो किसी न किसी का बाउंडर की तो ही है। We don't have time for family and friends. Quality of life is very bad. एक और चीज बड़ी खराब है, जनरल नॉलेज बड़ी खराब है हम लोग की। अखबार सुबह सुबह पूछता था मैं अखबार में क्या हेडलाइंस है, कोई नहीं बताता था। ना टीवी देखते हैं ना बीवी देखते हैं, पता नहीं क्या देखते हैं। पहला सवाल मुझको अखबार का हेडलाइंस बताओ, अभी क्या हुआ बताओ, यूक्रेन कहाँ, नहीं पता। अरे क्या यार, इसको मेडिसिन पढ़ के क्या पढ़ोगे कि लेसर ट्रेलेट साइन याद है लेकिन वो याद नहीं, तो बेकार की बात है। The bad at GK in current affairs. We don't have any say in medical matters. अभी कोविड में आपने देख लिया। Most of us we are spineless, to be very crude, but opportunities बहुत हैं और बराबर आप अपनी जिंदगी जरूर जीजिए। पैसा होगा तो भी यहाँ रह जाएगा, नहीं होगा तो भी। 3 चीजें आपके साथ जाती हैं, जो आपने एंजॉय किया है, आपने जो दूसरे को मदद की, और जो आपका इंटेलिजेंस है, और जो आपका हुनर है, वो आपके साथ जाएगा। लता मंगेशकर कोई नहीं बन सकता, मोहम्मद रफी कोई नहीं बन सकता। Always lead a good quality of life. You have only one life. You can have 4 wives, but only one life. Do not compromise on your ethics and values. ज़मीर जरूर आपका जिंदा रहे. Passion too should not be negotiable. Thank you very much. Any questions I will try to answer.
Thank you, sir.
2 भाषा, अंग्रेजी और हिंदी, 2 भाषा मैं बोलूँगा, एक उर्दू। हजारों साल, अल्लामा इकबाल साहब का शेर है, हजारों साल नरगिस मदर नेचर, हजारों साल, बस नरगिस अपनी बेनुड़ी पे रोती है, तब जाकर होता है ऐसा दीदावर पैदा। संस्कृत में चौथी भाषा ये बृहद अरण्यक उपनिषद का है। पूर्णमदः पूर्णमिदं पूर्णात् पूर्णम उदच्यते पूर्णस्य पूर्णमदाय पूर्णमेव अवशिष्यते।
So
Translation in English, hold on. He is perfect. Purnam idam. Purnamada. The audience is perfect. Purnat Purnam udachyate. And what the deliberation came out of you was really perfect.
Thank you, sir. Sir, with this, we would like to present a memento to you, sir. We request the chairperson to kindly hand over the memento. Thanks.
We would like to begin our next session related to pancreatobiliary conditions. For our next session, in this segment, we would like to invite distinguished chairpersons to have their seat on the dais. Dr. Chiranjeevi Khandelwal is Senior Consultant Surgeon at Paris HMRI, Patna. Dr. Manoj Kumar is Senior Consultant Gastroenterologist in Patna. Dr. Shashi Singh Pawar, Senior Professor in Department of Oncosurgery, IJMS, Patna. Dr. Ashish Kumar Jha, Additional Professor in Department of Gastroenterology at IJMS, Patna. Dr. Kunal Prasher, Associate Professor in Department of Surgical Gastroenterology at AIIMS, Patna.
We will speaker Dr. Vikas Singla to kindly come up on the dais.
So, over the next 15 minutes, we will be discussing regarding the medical management of gallbladder cancer. So, gallbladder cancer is the most common cancer of the biliary tract, and unfortunately, when we diagnose the gallbladder cancer, mostly the patient has an advanced gallbladder cancer. And the reason being, there are no specific symptoms for the gallbladder cancer. Like for the CA colon, we have symptom of anemia of the colonic obstruction. For the gallbladder cancer, at the early stage, we don't have any symptoms. And many times we diagnose GB cancer during surgery, either in the histopathology or during the surgery. And most of the GB cancer, they have aggressive behavior and they have a extremely poor prognosis. And surgery is the only curative treatment. And as a gastroenterologist, we have a limited role in the management of GB cancer. So we'll be discussing regarding the epidemiology, etiopathogenesis, diagnosis, and the medical management. So this slide is very important. We can see the gallbladder is different from the other part of GI tract. In gallbladder, we don't have submucosa, we don't have a muscularis propria. So this tumor spread very fast. When the tumor starts in the epithelium, it spread very fast to the muscularis layer and it spread to the other organ. We don't have submucosa, the muscularis mucosa. It can protect against the spread of gallbladder cancer. And gallbladder is attached to liver on one side and the peritoneum on the other side. So biliary tract cancer can be either a cholangiocarcinoma or it can be a gallbladder cancer. And gallbladder cancer is the most common biliary cancer, and adenocarcinoma is the most common pathological diagnosis. So this is the epidemiology. Certain areas of the world has a high incidence of gallbladder cancer. North India, Northeast India, East Asia and South America, these are the areas where gallbladder cancer has high prevalence. India has a high incidence of gallbladder cancer and the incidence is further rising. So the data show that in 2004 the incidence was 6.2 per lakh and it has increased to 10 per lakh in 2014. So this graph shows the area where the gallbladder cancer is high. You can see in India or the South America, the incidence of gallbladder cancer is the maximum. So in India, certain areas have the high incidence prevalence. North India, Central India, and the Northeast India, these areas have a high incidence of gallbladder cancer. And in North India, the incidence is 11 per lakh, and Northeast India, it's a maximum 17 per lakh. And the most common age is 5 to 6 decades when we diagnose the gallbladder cancer, more common women. And when we diagnose the gallbladder cancer, 80 to 90% of patients, they have the gallbladder stone. And it has been seen that the incidence of gallbladder cancer is out of proportion to the gallbladder stone. So the gallbladder stone is not the only factor behind the cancer. So there are other co-factors which are responsible for the cancer formation in a patient with the gallbladder stone. And this is again shows that the certain districts of India, these are mainly the district in northeast or the Delhi or from the central India, they have the high incidence of gallbladder cancer in the women and the men both. And this Kamrup district is a district in the Assam, very high prevalence of gallbladder cancer. So now if you see the pathogenesis, gallbladder is a small organ, but it's a very common site for the gallbladder cancer. So the reason is the gallbladder stasis. So gallbladder has a weak muscle. So the contraction in the gallbladder is very weak, and gallbladder has to empty against the gravity. And we can see fundus is a dependent area, and it has to empty against the gravity. And gallbladder has a high concentration of toxic substances. Many toxins are excreted in the bile, and bile is concentrated in the gallbladder. So there are toxins in the gallbladder, and gallbladder has a poor contraction, and this leads to bacterial infection, and the bacteria can deconjugate the bile salt, and this can lead to accumulation of again toxic bile salt in the gallbladder. And sometimes if there is a stone can act as a nidus for the bacterial infection. So it's a state of chronic infection and the inflammation, and chronic inflammation can lead to mutagenesis, dysplasia, and the cancer. So this slide explains the pathogenesis. So there is a susceptible host, there is a vulnerable gallbladder, and there is an environmental factor. So it's more common in the female and in the 5th and 6th decade, and patients who consume tobacco and the obese are the more prone for the gallbladder cancer. And what is the vulnerable gallbladder? The gallbladder which is more prone to stasis, like the patient who is having cholelithiasis, or if there is a abnormal pancreatobiliary union, Xanthogranous cholecystitis, and the porcine gallbladder, these are predisposed to the gallbladder cancer. And then there are the environmental factors like Salmonella typhi infection, Helicobacter infection. Then there are irritant like the mustard oil, or the high amount of nickel, cadmium in the bile. All this predisposed to gallbladder cancer. That may be the reason in the Ganges belt the gallbladder of cancer is high, maybe because of these toxins in the soil or in the river. So this slide explains the gallbladder pathogenesis in a patient with the chronic cholecystitis, a state of chronic inflammation. This will lead to metaplasia and the accumulation of various mutations. This will lead to dysplasia, early flat gallbladder cancer, and which can later on form the mass lesion. So if we see the symptoms, so half of the gallbladder cancer are diagnosed during the surgery, and the remaining half of the patient may come with the symptom of gallbladder cancer. The study from the AIM showed that the most common symptom of gallbladder cancer either are a pain in the right hypochondrium due to the mass formation and invasion of surrounding neural structure or the surrounding liver. If the tumor is arising from the gallbladder neck, it can invade the bile duct and can lead to the jaundice. Hepatomegaly indicates either there is a biliary obstruction or the liver metastasis. Patient may have pruritus also. And many times patient can come with the ascites or feature of gastric outlet obstruction. Hematemesis is a rare feature. And many times patient can have pharyngitis also. So how once we suspect the gallbladder cancer, ultrasound is the most common modality. So if on ultrasound there is an asymmetrical gallbladder wall thickening, or there is a biliary obstruction and large periportal or the paraiotic nodes or the liver as well, in a patient with a gallbladder stone, the CAGB should be suspected. CT can define the mass better, and it's an excellent tool for the resectability. We can look for the nodes, liver metastasis, and the involvement of portal vein and the hepatic artery. Again, PET is a tool for the defining the resectability. So once we are suspecting the gallbladder cancer, the tissue diagnosis is not mandatory. Patient can straight away be taken for the surgery. For the unresectable lesion, we need a tissue diagnosis. Either the ultrasound guided or the CT guided sampling can be done. Sometimes there is a small tumor at the GB neck. In those cases, we can do the US guided fine needle aspiration. The study we conducted at Sir Gangaram Hospital, this is the largest series across the globe. 110 patients who had a GB neck lesion, and we found that it has a very high sensitivity, more than 90%, very high specificity, and a good positive predictive value. So in patient where the ultrasound guided sampling or the CT guided sampling is not feasible, we can do the US guided sampling of the gallbladder mass lesion. So these are various differential diagnoses. Many times patient with the Xanthogranous cholecystitis, they can present with the diffuse thickening of the gallbladder, especially in the diabetic patient. So if there is a diffuse symmetrical thickening, one can think of benign etiology like Xanthogranous cholecystitis. If there is asymmetrical thickening, the malignancy is more likely. Sometimes patient with the Mirigy syndrome, again there can be a mass lesion along with the stone at the GB neck. So EUS may be helpful in this scenario. Like here we can see there is some compression of the at the mid CPD by the GB neck. So either it can be a stone or it can be a small mass at the GB neck. So in this scenario, ES may be helpful. And hilar cholangiocarcinoma, if it's a mass forming, it can be again confused with the carcinoma gallbladder. Acute or chronic cholecystitis can lead to the diffuse thickening of the gallbladder, and the malignancy may be suspected. And patient with a large polyp in the gallbladder, it can be a gallbladder malignancy. So whenever we have a polyp in the gallbladder, if a polyp is less than 5 mm, it's likely to be benign, unlikely to be malignant. If polyp is between 5 to 10 mm, there is a chance of malignancy, especially if the patient has gallbladder stone. So one should do US and CT scan to find out whether polyp is benign or malignant. And mostly the polyps are benign and used to follow the patient. If the polyp is more than 20 mm, it's likely to be adenomatous or the malignant polyp, and surgery should be offered to the patient. If polyp is between 10 to 20 mm, there are two options: either we go for surgery, or if it's one can do the CT or PET scan or US. If there are feature of malignancy on CT, US or PET scan, patient can be taken up for the surgery or patient can be followed up. So polyp which are more than 10 mm are likely to be malignant polyp and they should be offered surgery. So once we diagnose the gallbladder cancer, we have to stage. We have to do the T&M staging. So CT is the most common modality used to stage it. And T1 is the tumor confined to the gallbladder. So T1A is the tumor confined to the lamina propria, and T1B is the tumor which is invading the muscle layer. For T1A, it's diagnosed basically on the histopathology, and no further treatment is required. T1B will require the additional surgery. And in T2A, there is involvement of perigallbladder connective tissue, and 2A is the towards hepatic side, and 2B is the towards the peritoneal side. Then stage 3 is the involvement of surrounding organ, either it can be a liver or it can be a pancreas. Stage 4 is involvement of hepatic artery or the portal vein, or there can be involvement of two adjacent organs. T4 lesions are unresectable, they should be treated with chemotherapy. Many times with the chemotherapy they can be downstage and can be operated. Up to T3, the treatment is surgery. And for the end staging, if there are 1 to 3 nodes, it's N1. More than 4 nodes, it's a N2. M1 is the patient having distal metastasis. It can be node in the left supraclavicular area. M1 again is a contraindication for the surgery. So T4 and M1 disease is a contraindication for the surgery. And similarly, the patient has celiac nodes, paraiotic nodes, or nodes around the SMA. It becomes a contraindication for the surgery, and patient should be offered neoadjuvant therapy, and the downstaging should be attempted. So this algorithm shows how we should manage the patient with the gallbladder cancer. So if the patient is having gallstone disease on ultrasound, and if there is no suspicion for the gallbladder cancer, surgery should be offered. And if there is an intraoperatively, if surgeon is suspecting it's a GB cancer based on the direct endoscopic, direct laparoscopic appearance, it should be converted to surgery. If the hepatobiliary surgeon is available in the same setting, it should be converted to the open surgery, and the extended surgery should be done. If the surgeon is not available, the staging should be done by CT, PET or MRI. If there are distant metastasis, chemotherapy should be offered. If no metastasis, surgery can be done. If the tumor is diagnosed only on the histopathology and it's a T1A, the lap cholecystectomy is sufficient. No additional thing should be offered. On the other hand, tumor which are T1B involving the muscularis propria or the surrounding organs, one should do the additional staging with the CT, MRI or the PET scan. If no distant metastasis, surgery should be done. On the other hand, many times we have a suspicion of gallbladder cancer on ultrasound or the CT scan. If there is a metastasis, one should offer the chemotherapy. If there are no evident metastasis, or if there is suspicion of cancer on the ultrasound, one should do ultrasound, CT and MRI. No metastasis, surgery. Do the PET scan, again no metastasis, there should be laparoscopy. If on laparoscopy no metastasis, one should go for the laparotomy and the resection. If metastases are detected either by the laparoscopy, CT or PET, one should be offered the palliative care. And now there is a increasing role of neoadjuvant therapy, especially in the patient who have advanced stage like T4 stage or T3 stage, or the surrounding lymph node positive patient. They may have a benefit with the neoadjuvant. Neoadjuvant will take care of the micrometastasis in the lymph nodes, and it can downsize the cancer also, and more arterial resections can be achieved. And it can also lead to the better patient selection. If during the neoadjuvant patient doesn't have disease progression, it indicates it's a benign behavior. Such patient may benefit better with the surgery. And the gemcitabine and the cisplatin are the favored agents for the neoadjuvant. And it has been seen that even after surgery, the patient has a poor survival. 5-year survival is around 28%. And these patients, so even after arterial resection, patients are offered chemotherapy. Various regimes are mitomycin and 5-fluorouracil, gemcitabine, oxaliplatin, and the capecitabine. And most of the patients, they have a unresectable gallbladder cancer, and they should be offered chemotherapy. It has a survival benefit of 3 months, and the most common modality regime is the gemcitabine and the cisplatin. The alternate is the 5-fluorouracil, gemcitabine or the oxyplatin. If patient doesn't respond to the conventional chemotherapy, the second option is the targeted chemotherapy. So various targets are the either HER2, which can be targeted with the trastuzumab. Then one can use the fibroblast growth factor inhibitor or the isocitrate dehydrogenase inhibitor. With these inhibitors, the survival benefit is around 2 to 3 months. So we can see that even after the targeted therapy, the survival is very poor for these patients. And now there is an increasing role of the immunotherapy. It has been seen that gallbladder cancer, the patient has an immunosuppressed environment in the gallbladder. So we can use the immunotherapy, which is a PD-1 inhibitor. We can use the nivolumab or the pembrolizumab. It can increase the survival by around 3 to 6 months. So this is a unique situation, gallbladder cancer with the jaundice. As a gastroenterologist, we routinely see patients who have a gallbladder cancer involving the neck, and the jaundice is mostly due to the direct invasion of the common bile duct. And it has been seen that once the patient with the gallbladder cancer has jaundice, it's a suggestive of poor prognosis. And when the patient has a CBD invasion, it's difficult to achieve the R0 resection. The jaundice can be due to either compression of the bile duct or invasion of the bile duct. If it's due to compression, there can be possibility of R0 resection. But if the mass is invading the bile duct, it's unlikely to be R0 resection. And when time we perform the ERCP, I think one has to be very particular about the performing ERCP in these patients. The indications are prior to neoadjuvant therapy or prior to surgery. Not all patients with the gallbladder cancer should be offered biliary drainage. And many times patients for the palliation like itching or cholangitis, we can offer the ERCP. And for type 1 block, where the conference is patent, or type 2 block, where there is a conference is blocked but not involving the right or left duct, the ERCP can be preferred. But in patient with the type 3 and type 4 block, there is high risk of cholangitis after ERCP. Biliary drainage should be avoided. If required, one should go for the percutaneous biliary drainage. Yeah, last one. So, yeah. So to can I go to last slide? So to summarize, gallbladder cancer has very poor prognosis, and mostly the patient has associated gallstone, but they again require the cofactors to develop the gallbladder cancer. Incidental gallbladder cancer can be detected incidentally during surgery, or the patient can present with the symptom pertaining to the gallbladder cancer. Surgery is the only curative treatment, and chemotherapy has a very limited efficacy, and patient with the jaundice with the CBD invasion has poor prognosis. Thank you very much for your patient hearing.
Thank you, sir, for your deep insights on the topic.
Mandal sir on the dais. Dr. Manish Mandal sir is Senior Professor and HOD of Surgical Gastroenterology at IJMS Patna.
Thank you, chairpersons. I'll be in my talk today. It's a very important topic for all of us because it's there in every family, I would say. And the pity is that most of the patients are in advanced stage. So coming to my talk, it's already discussed by my previous speaker. Most commonly malignancy in biliary tract, only 15 to 30% are resectable when diagnosed, and more frequent in females than males. These are the ethnic groups. This is the normal pictorial diagram of hepatobiliary showing the gallbladder. This is already discussed by my previous speaker in detail of the histopathology, so I won't waste my time in this. As you know, Japanese have very keen interest in going for the lymph node dissections. So I have just denoted the lymph nodes and the pictorial diagram, Japanese nodal nomenclature. This has also been discussed by my previous speaker in detail about the TNM staging. Now coming to the point as a surgeon, when we do workup of these cases, we are mostly concerned with the liver function test, the tumor markers, and of course the diagnostic imaging is very, very important for us as a surgeon, where ultrasound is the mainstay, and the last laugh is by CT scan. Rarely we go for MRCP, US or PET scan where need, but routinely we don't go for these tests. imaging characteristic of GVC is GV adenocarcinoma presents in one of the three imaging morphology. First is intraluminal mass, second is intraluminal wall thickening, and third is mass replacing gallbladder. Most of the cases which come to us are like this. Mass is replaced by the gallbladder itself. So, this diagram has shown the picture of the intraluminal mass. This is showing again the mass, the polypoidal mass in the fundus. This shows the normal local thickening of the gallbladder. And this shows the continuous extension of water mass into the liver, where you can see the pointer pointing all over in the liver. This is again the mass. And the new armamentarium is endoscopic ultrasound, which is done when there is a confusion state and when the wall is very thick and you cannot make about whether it is infiltrating or whatever, then we go for this. So polypoidal mass in neck gallbladder is shown in this picture. Tumor invasion confined to mucosa or muscular mucosa, that is TIS, PT1, PT-A1B, then stage 0 and stage 1A. PT1A, local disease spreads locally, PT1B spreads regionally and systematically. Critical factors in surgical management. This is the most important for us as a surgeon. That is location of the tumor, extent of local invasion, involvement of liver, involvement of nodes, involvement of bile duct, involvement of vessels, pattern of tumor biology, and pattern of disease spread. So this is important. अगर हमें ऑपरेशन करना है तो इस सब चीजों को देखना पड़ता है डिटेल में, तभी ऑपरेशन करना है. Aim of all this is to have an R0 resection. So what are the options which we have? Depending upon the stage of the disease, we have simple cholecystectomy where it's just stage T1A, or it can go to extended or radical cholecystectomy, or it can go to radical cholecystectomy with segmental or lower liver resection, or if it is still more than radical cholecystectomy but bile duct excision when CVD is involved. If it is still further involvement is there, then we have to do radical cholecystectomy with pancreatic pneumotomy, that is PD. And if still it's more advanced, then rarely we go for this radical cholecystectomy with HPD. Extent of resection as per stage of GVC. Patients presenting with gallbladder mass on imaging or operative exploration. These are the options which we have. This is the pictorial diagram of an NCCN guideline. These are prognostic factors of T2 lesions, as positive margin, papillary versus other tumor types, tumor within 5 mm resected margin, lymph node metastasis, tumor grade, and perineural invasion. Then a word or two about incidental CHE. Gallbladder cancer is found in 0.2% to 2% of all laparoscopic cholecystectomies. Simple cholecystectomy is optimal treatment. 5-year survival rate is about 100%. Recurrence rate is 1.1%. Most frequent site of recurrence is CBD. There most of us see that it is patient coming with jaundice to us. Cystic margin, if positive, then extrahepatic VHPD resection is done. Lymph node metastasis has been reported in less than 2.5% cases, and lymph node dissection is not indicated. Bile duct juice leakage during laparoscopic cholecystectomy is associated with peritoneal metastasis and tumor resection recurrence in trocar sites. So as a surgeon, it's very important for us that if anybody has had lap chole and the diagnosis is CAGB, then we have to take care of the ports also. No established recommendation regarding timing of surgery as soon as it is diagnosed. So what we follow that the patient should reach to us after the previous surgery at the earliest, maximum within 1 month. Incidental GVC surgical management. So as I told before also, if it is TIS, T1A, then no further treatment. If it is T1B, surgical resection of the margin. If it is negative, no further treatment. If it is positive, then radical cholecystectomy. If it is T2, then directly radical cholecystectomy with both sides excision. If it is done laparoscopically, extended cholecystectomy, staging of the any patient planned for extended chole. First, we have to do staging laparoscopy, because many a times, even if we do CT scan, the patients on table are diagnosed of having malignancy, especially liver mets. So any patient of CAGB, if planned, should undergo staging laparoscopy. So this is the pictorial diagram showing the hepatomegaly sepsis with reports which are involved and which has to be taken care of during the surgery. Role of formal hepatectomy. GV neck tumor, T2 infiltrating adjacent liver, T2 body tumor and T3 tumor. These are the cases where we have to go for formal hepatectomy. Excision of bile duct. Most of the T2 or T3 lesions where the lesion is to the neck or cystic duct tumor, to achieve complete tumor resection, it is suspicion of bile duct infiltration, and if cystic duct margin is positive. So this is the pictorial diagram we are seeing. This is how we mark when you undergo liver resection during the operation. These are the marks which we make. This is the process of surgery. Here we can see the vessels being dissected out. Here we can see the lymph node clearance and the bare area of the CBD. Here liver resection is showed with total bare area of the CBD, which we can see above. The specimen resected out. This is again the specimen showing mass in the bed in the body area. So operated patients in IGMX cases last 5 years is 491 cases which we have operated here. The ratio was male is to female was 1:2.5. Age range was 23 to 90 years. Mean was 51 years and mean 51.9 years. Extended colostomy was done in 224 cases. Bypass, whatever form was done in 2 cases. Staging laparoscopy plus biopsy 201 cases and HPD in 4 cases. Out of this, the details are as shown in the picture. Extended coli 224 case mortality was 9 out of 224, that is 4%, and mortality was 71%. Many of them had wound infections because in between we had a series of wound infections. And during that, this case was seen. Bile leak was there in 22 patients and post-operative hemorrhage in 5 patients. Our problem, since this is a disease of whole northern India, especially northeast India, and our problem is cases come quite late when they have already had jaundice, when the CBD is involved, when they have metastasis or a huge lump, huge mass. So hardly 50 to 20% are fit for curative surgery. Out of that, when we go on table, 5% are still inoperable. So practically only 10% patients are operable when they are on table. What to do? So we all have to think that we have to do early detection and treat, and this can alter its natural history. And there should be awareness between amongst all of us, especially surgeons, physicians, and patients also. So in summary, most of the early gallbladder cancer are incidental diagnosis. If on histology the disease is PT1A, then no further surgery is required. If it is PT1B, pre-operation complete extended colostomy is required to select group with port site excision. If it is clinically diagnosed or in imaging, are usually advanced stage. Staging laparoscopy is recommended in most majority before doing laparotomy. Extended colostomy is required in T1 and T2 disease. Need of formal hepatectomy or bile duct excision is decided on case-to-case basis. More extended form of radical surgery like BD and IUD with extended colostomy is usually not advised in early CAGB. So take home message. Any wall thickening or lymph node in ultrasound, we must think of malignancy. Even if there is just wall thickening, with or without smoke, we have to think of malignancy. Then only we can catch these cases early. And at every gallbladder surgery, you must open seal the gallbladder. If there is any growth, send for imprint cytology or frozen section where it is available, and then proceed accordingly. Surgical management is the only curative management which has been told by my previous speaker also. Gallbladder cancer early surgery is associated with better outcome. High volume centers have better outcomes. Facility for imprint cytology or frozen section is imperative. And for incidental gallbladder cancer, complete OT node for index surgery is very low. I mean to say that if the surgery is done outside somewhere else and it is sent to a high volume center, a proper OT node is very important for the next surgeon to operate so that he can do his best for the patient at the given time. Thank you all for patiently.
Thank you, Dr. Manish, and may we request Dr. Vikas Singla to come on the But wonderful speech, Dr. Manish Mandal. You have directly as subject given to you. You have given a very comprehensive and knowledgeable, informative talk. And I can say that 500, almost 490 cases in 5 years, maybe very few hospitals in the world, what to talk of India, they will have such a great experience simply because the incidence is high. And whatever you have said is, I like, in fact, I wanted to comment on the talk of Dr. Singla. He talked everything except the medical management per se. He talked etiology, pathology, prevalence, TNM, everything, whereas he should have focused on the talk of, and he talked of surgery also. In his talk, there are 2 points if you want to take up those 2 questions. He highlighted that chronic inflammation, etiology. My understanding is that if chronic inflammation, it should be squamous cell carcinoma, whereas it is adenocarcinoma. And then all the countries where gallstone is high, including US and European countries, the incidence is not high. So that is not the pathogenesis or the hypothesis. So I wanted to ask him, but he has left. Secondly, he has highlighted that incidental diagnosis on table and those things. Incidental word is now reserved, as you rightly said. The post-operative histopathological surprise is the word when we talk of incidental. You have delivered a very good talk. I would request other person to comment, and I have no particular question except that you could have added aortocaval lymph node FNAC either laparoscopically or EUS guided. Because this is another thing which is going to help us to inform whether we should go ahead for surgery or not.
That is not accepted in
What prevents you from going ahead? What finding at laparoscopy? Is it extension of the disease, it's peritoneal metastasis? What do you find which precludes you from going ahead?
It's a set of things which is already given.
In your experience, you have a
normally, sir, they have liver mets, number 1, or peritoneal mets, number 2, or there is a frozen carrot style. No jaundice, but frozen carrot style.
So frozen carrot style will be contraindicated.
Now we have just started. One of our MCA students is doing his thesis on this. We are taking peritoneal wash on the table, getting it done. So we have tried this thing to be done.
Photo photography session. Moving on to our next session, which would be on management of chronic pancreatitis. We would like to invite our chairpersons from the session, Dr. Bharatendu Kumar, Department of Surgery, SKMCH, Muzaffarpur, Bihar. Dr. Rakesh Kumar Singh, Additional Professor in Department of Gastroenterology at IGMS, Patna. Dr. Shantu Mohan, Senior Consultant Gastroenterologist in Patna. Dr. Avnish Kumar, Consultant Gastroenterologist at Rubin Hospital, Patna. Dr. Gyanendu, Senior Consultant Gastroenterologist in Patna.
May I request our esteemed speaker of the session, Dr. Sameer Mohindra, to come up on the dais. Dr. Sameer Mohindra is Professor in Department of Gastroenterology. Topic for discussion is optimizing medical management of chronic pancreatitis. May I kindly request him to please begin with his speech.
Good afternoon. First of all, I want to thank the organizers for making me a part of this. It's always a pleasure to come to Patna. It's been almost, I think, 8 years. And coincidentally, last meeting was also in the same one. So I've been asked to speak on a very important topic, chronic pancreatitis. How do we manage them medically? I personally feel that despite advancement in endoscopy and surgical techniques, medical management still has got a lot of say in managing these patients. Yeah. Chronic pancreatitis is basically chronic inflammation associated fibrosis which is irreversible, leading to abdominal pain with exocrine and endocrine insufficiency and predispose these patients to malignancy. If you look at epidemiology, it depends upon which part of the world we are dealing with. This is a Western graph which shows that predominantly patients have alcoholic etiology, especially in the 3rd to 5th decade. While if you look at Indian data, approximately 2/3 patients are non-alcoholic. And males outnumber female by a ratio of 1:1, 1.2:1. Now, if you look at chronic pancreatitis, there can be systemic complications and there can be local complications. The local complication can be stones, can be strictures, can be masses, can be obstruction of pancreatic duct, biliary duct, or even gastric outlet obstruction, and 10 to 15% can have vascular complication in the form of thrombosis and if you look at systemic complications, common systemic complications are diabetes mellitus, osteoporosis, malnutrition, sarcopenia, gastroparesis, which can be disease-related or therapy-related, and occasionally find patients with small visceral bacterial in these patients. So we need to look at the associated problems with chronic pancreatitis before we manage these patients. Now this graph everybody must have seen, but why I put this slide is, we need to determine the etiology of chronic pancreatitis in every patient. There are two reasons. There are certain causes like smoking, alcohol, hypertriglyceridemia, hyperglycemia. If we treat those, it slows down the progression of the disease. Number two, there are various conditions where you have more than one etiological factor. For example, if you have alcohol, if there is PINK1 and CTRC mutation associated, progression of alcoholic chronic pancreatitis is much faster. So we should get some idea about what etiologies we are dealing with. This is a national North American pancreatitis study group which looked at etiology of more than 500 patients. What this slide shows is that alcohol constitutes almost 50% of chronic pancreatitis in the West, autoimmune 2.2 and 8.7. Why I highlight these 3 points are that they are correctable factors. If we correct these factors, then the progression of chronic pancreatitis will be much slower. Outline of chronic pancreatitis includes management of pain, management of exocrine endocrine insufficiency, and management of associated complications. Now, these patients are a heterogeneous group of population because it depends upon the etiology, whether they are alcoholic, non-alcoholic, whether they have obstructive disease or a non-obstructive disease, whether the main pancreatic duct is dilated or not dilated, whether when the patient comes to you has got active inflammation or it's a quiescent disease, because the management depends upon whether the patient has active inflammation or a quiescent inflammation, especially when we are dealing with interventions. Pain is the predominant complaint seen in more than 90% cases. We all know about type A and type B pain, but now there is a concept of type C pain. Type C pain is chronic severe pain requiring opioids. Now A, B and C, now there are 3 pain patterns which are highlighted in patients with chronic pancreatitis. We should know what kind of pain which we are dealing with, because the therapeutic strategy depends upon the severity and the frequency of pain. Now, mechanism of pain is multifactorial. There are multiple domains. It is considered to be initially visceral in origin, and then it becomes more of a neuropathic and psychogenic. And what you have to realize is it can be because of local complications, and now concept is coming of a neuro remodeling which is happening, and which leads to central hypersensitization and peripheral hypersensitization. So now we are looking at a neurological aspect of pain in chronic pancreatitis also, especially when the disease is prolonged. This slide basically shows that there is a lack of correlation between the morphology of the duct and the severity of symptoms. Patient may have very severe disease on imaging, but patient may not have symptoms or minimal symptoms. On the other hand, for example, small duct disease, patient may have minimal morphological changes, but symptoms are much more severe. We don't have an ideal comprehensive pain assessment tool so far, and we don't have enough knowledge about the natural cause of chronic pancreatitis, especially with different etiologies. And now the role of neuropathic pain is coming up, which we are learning now how to deal with it, but still there is a long way to go. Now, when we assess pain, what we have to realize is not the intensity of pain. What we need to look at the intensity, we need to look at frequency, we need to look at need for analgesics, and the effect of quality of life. Previously, we used to look at visual analog scale on the left-hand side, which was kind of a very subjective. Now, we very often use a speaky scale, which looks at the visual analog scale, frequency of pain attack, need for analgesics, and the quality of life because the work being affected. So now we need to be more objective in assessment of pain before deciding what strategy of pain management has to be done. Medical management cornerstone is analgesics. Pancreatic enzyme is controversial, which I will discuss, and then we need to manage complication which will contribute to pain in a particular patient. If there is evidence of obstructive pathology, we need to deal with that. Surgery is needed in very minority of patients. But there are different modalities to treat pain. One is risk factor elimination or minimization. For example, if a patient is smoker, there are higher chance of developing calcification, there are higher chance of developing persistent pain, there is a higher chance of non-response to endotherapy, and there are more chances of pancreatic endocrine insufficiency. Similarly for alcohol, we need to look at the risk factor in a particular patient. Then if there is intraductal hypertension, we need to treat that. Analgesic is the backbone of managing these patients. We need to look at associated affective disorder. That is, many of these patients have anxiety, depression. We need to look at that angle also. Neuromodulation strategies are coming up which try to treat the neuropathic pain. But before treatment is initiated, we need to look at all factors which are playing a role in causation of pain in a particular patient. It's not only a local pathology which is causing pain. So the mainstay of treatment are basically four: analgesics, cessation of alcohol and tobacco, antioxidant and pancreatic enzyme therapy, which I will discuss one by one. Analgesics, if there's a mild pain, we start with paracetamol or maybe non-steroidal anti-inflammatory drugs. If pain is moderate, then we use weak opioids like tramadol, and if pain is severe, then we use morphine. Oxycodone is coming up as a very good analgesic agent in place of morphine. What we have to realize is that it has to be balanced. The use of opioid has to be balanced with the risk of addiction, number one. Number two, addiction risk is much higher in patients who are alcoholics, and therefore we, in addition to non-opioid drugs, we try to use adjuvant analgesics. Basically, they include anticonvulsant, anxiolytics, and antidepressants. Tricyclic antidepressants, SSRI are coming up in a big way as an adjunctive analgesics. And gabapentin, studies have shown that gabapentin with antioxidants do have some role in spondyl disease, though the data is not enough, but they are good adjunctive therapy in addition to analgesics. These are the various drugs which we use. Cessation of alcohol and tobacco is very important because it has been shown that if smoking is stopped, then there is a chance that patient will not develop pancreatic calcification, insufficiency, and they respond better to endoscopy is done. And studies have shown that people who are abstinent from alcohol, they have a 50% reduction in having persistent pain. Cessation of alcohol and tobacco is very important. Pancreatic enzyme therapy for pain is a very controversial topic. The whole concept is you give proteases to the lumen, then CCK releasing peptide is reduced, then there is increased baseline secretion of the pancreatic juice. We generally use non-nitric coated. We want the enzyme dissolved in stomach or duodenum so as to stimulate the axis, and then we use PPI along with it, and non-nitric coagulation is preferred. Now, there is lack of it, but we occasionally use it in two categories of patients. One is small duct disease where there is no medical, although endoscopic or surgical option possible, and number two, when they have symptoms like bloating, gaseousness, dyspepsia, their pancreatic enzyme may play a role in symptom resolution, but it's of no use in large duct disease or advanced chronic pancreatitis. Neurological and psychological intervention, which include behavioral therapy, cognitive therapy, hypnosis, stress management, these are very important strategies which are coming up in treating these patients, especially when we think that's more of a neuropathic pain. And what we have to realize is why these strategies are coming up, we don't want a chronic opioid abuse because it leads to paradoxical hyperesthesia, which can make pain worse. Role of antioxidant, you want to decrease nociceptive stimuli, particularly the ischemia, because of reducing oxidative stress. It can play a role. A very good study from Dr. Pramod, which showed that there is a need for anesthesia is much lower, number of painful days are much lower, number of painful days in a week are much lower, and this study showed that antioxidant work. Similar study from the West, it was a negative study. The reason was the category of patients which they discussed was not the same. In Indian study, most of the patients were undernourished, non-alcoholic, non-smoker, younger. While in the Western study, most of them were smokers, alcoholics, they were older, and they were not undernourished. So antioxidant may play a role in a subcategory of patients with chronic pancreatitis who are young, non-alcoholic, non-smokers, and undernourished. So we need to dissect which category of patient will respond to antioxidants. So to summarize, steps in pain management are: we make a correct diagnosis, whether it's chronic pancreatitis. We do a good cross-sectional imaging. It can be CT, MRCT, or US, whichever is available. All are similar. We need to look out other alternate diagnoses which can contribute to pain. Look at complications, local and systemic. Superimposed pancreatic CA, not an uncommon complication which can worsen pain. And of course, biliary and duodenal obstruction. If they are candidates for endoscopy, go for endoscopic procedure, but intraductal decompression. If it doesn't work, then the patient is a candidate for surgery. If patient is not a candidate for endoscopic therapy, then we go ahead and do the medical treatment which I mentioned today. If it doesn't work, then surgery is always an option. Now coming to pancreatic enzyme insufficiency, when we use PERT, why, when and how? Pancreatic enzyme insufficiency is a reduction in pancreatic enzyme activity to a level which does not maintain the normalization. In chronic pancreatitis, because of two reasons, ductal obstruction and pancreatic parenchymal loss. Pancreas has got a very good reserve, and more than 90% SNI have to go manifest as pancreatic enzyme insufficiency clinically. And chronic pancreatitis is the commonest cause of pancreatic enzyme insufficiency in the world. How common it is? At one point, 40% patient of chronic pancreatitis will have pancreatic enzyme insufficiency, but over a period of time, 70% patients with chronic pancreatitis eventually develop enzyme insufficiency. This is also common in diabetes mellitus type 1, type 2, as well as CKD and inflammatory bowel disease. So who should be screened for pancreatic enzyme insufficiency? For number one, newly diagnosed chronic pancreatitis, newer symptoms which may come up, and once we diagnose pancreatic enzyme insufficiency, we have to check it regularly, at least annually, so as to see whether the therapy is effective or not. Grades, mild, moderate, severe. We see mainly the severe form, which is also known as decompensated chronic pancreatitis, because exocrine or endocrine insufficiency involves where the enzyme related to the bowel is reduced, bicarbonate is reduced, and patient is This is a busy slide. What it basically shows is that there are multiple etiologies of pancreatic enzyme insufficiency. It can be because of parenchymal loss, ductal obstruction, hyperchlorhydria, poor neurohormonal control of enzyme release from the bowel, and all different etiologies cause pancreatic enzyme insufficiency. Now, the etiology also plays a very important role. And chronic pancreatitis, they have got an earlier onset of pancreatic enzyme insufficiency as opposed to severe. So etiology does play a role. Symptoms of pancreatic enzyme insufficiency are very non-specific. And what happens, sometimes these patients reduce fat reading. So the symptoms like steatoria, they are not very common. I can show that only 1/4 of patients with pancreatic enzyme insufficiency will have steatoria and presentation. Micronutrient deficiency clinically is very uncommon, but if you see biochemically it's a very common phenomenon, especially biochemically, which is in 70 to 80% patients. And when we assess these patients, we need to look at protein status, retinol binding protein, we look at creatine, creatinine, we look at vitamin D levels, and we look at trace element, mainly magnesium, zinc, and selenium. It's very important at the baseline. We review the symptoms when the patient comes to us for the first time. We obtain detailed patient history, rule out the differential diagnosis, and then do the study of these patients. There is an Indian study from Dr. Bhupendra Rawat and Dr. Kochhar which showed that almost 90% patients will have gain, 60% will have weight loss. And on the right side, you can see overt deficiency is not very common. We do direct, can I have 2 minutes? So if you look at diagnostic tests, we have direct, indirect. Direct test, we stimulate the pancreas and assess the enzyme and bicarbonate output. But now we are using mainly the fecal elastase. It's a very easily available, cheap test, and which is tolerant by the patient. Only one single sample. The only thing you have to remember is that diarrhea makes it false positive. And normal is less than 200, less than 100 is advanced pancreatic enzyme insufficiency. Sensitivity in mild to moderate is less, specificity is quite high. Once you have fat absorption, we don't do it generally because it's cumbersome. It's not easily acceptable to the person and it's not easily available. Normal CFT is more than 90.5%. But central of fecal fat, similar, more than 7 grams is considered normal and it can be used while monitoring the patient or enzyme. This is algorithm gradual. Patient comes with clinical symptoms and micronutrient deficiency. There is a background setting, for example, severe chronic pancreatitis, large pancreatic head tumor. What is post-necrotizing pancreatitis, there are part of, single part of the pancreas has gone, no test is needed, you can straight away go into the enzyme. The target is minimize the nutrient absorption, malabsorption, achieve adequate concentration of the pancreatic enzyme and enhance the food delivery. Diet, not much change to be done, normal diet, small frequent meal, normal fat, avoid high carb diet, but it makes enzyme less effective. Medium chain triglyceride, not important, vitamin A, D, E, K to be given. If symptomatic or serum levels are much more indicated for malabsorption, 80% respond to normal diet, enteral nutrition really indicated. These are the indications for pancreatic enzyme insufficiency. The third, steatoria with fecal fat of more than 15 grams is pathological pancreatic function with clinical signs of malabsorption or antidote evidence to treat. Treatment with PERT as a trial for 4 to 6 weeks can be given if the clinical suspicion is high. We all know that microsphere and mini microsphere are the way to go. Generally, we use mini microspheres and generally start with 30 to 50,000 units per meal and half the dose with snacks. When patients don't respond, we need to, how do we monitor? We monitor by the malabsorption or maldigestion related symptoms. We see the nutrition whether normalized or not. If they do not respond, then we go ahead and do a CFA or C13 mixed triglyceride test. Common factors for non-response are low dose, poor compliance, if the pH is acidic, and SIBO, which is seen approximately 30 to 40%. This is what I mentioned. This is EGW guidelines, which are same what I have discussed. Side effects, very minimal. Fibrosing colonopathy, I have never seen a patient, but it has been documented with a very high dose. Response to therapy is very good, whether you look at bloating, whether you look at fecal fat, whether you look at weight gain. This is the meta-analysis in gut, which said that it worked very well, especially entry-coated mini microspheres. So this is the algorithm. We treat them, no response, increase the dose 2 to 3 times, doesn't work, add PPI, no response. Then we look at other causes like celiac disease. We can look at small intestinal bacterial overgrowth, and we monitor these patients with anthropometric measures, GI symptoms, and certain blood tests which I have mentioned here. Just 2 minutes. These are very important slides. There are 2 entities which I want to discuss. Metabolic bone disease, that is CP-induced osteopathy. This has been very much overlooked. Approximately 2/3 patients will have either osteoporosis or osteopenia, and they have a high tendency to get low trauma fractures. There are various contributing factors, but what we have to realize is that we have to detect osteopathy and treat them, because this is a preventable kind of a complication which can be managed. Sarcopenia is another thing which we don't look at. People have shown that sarcopenic patients are more prone to hospitalization, and they have a higher mortality as compared to non-sarcopenic patients. Pancreatic cancer risk. This is another important aspect, that is surveillance of chronic pancreatitis patients. Whom do we need to surveil? Age more than 50 years, if there is recent worsening of symptoms, if there is recent worsening of sugar, if there is a mass which has come up in the background of chronic pancreatitis and hereditary pancreatitis after the age of 40 years or 20 years after the onset of symptoms. Triple phase CT is the investigation of choice. When we see a mass, we need to take the tissue. EOS guided FNA or FNB is the investigation of choice. The problem is, in the background of extensive pancreatic calcification, diagnostic yield of EOS guided biopsy reduces to 50 to 75%. But this effort has to be done. Role of elastography and contrast EOS is coming up, but it's still not proven. And if second biopsy is also negative, we personally talk to the surgeon and get the person operated. Because these symptoms of worsening chronic pancreatitis with a mass, despite a negative FNA or FNAC, these patients are a good candidate for surgery. Endocrine insufficiency, quite common, 40 to 50%. We need to do annual blood sugar, fasting blood sugar, and glycosylation. It's an independent predictor of mortality, predisposing factors I mentioned. Insulin is the drug of choice. Metformin may be tried, but these patients don't tolerate metformin easily, and sugar control is much poorer. And it's a very labile kind of diabetes, because there is basically decreased insulin as well as decreased glucagon. So it's a very fragile kind of a diabetes. A strict monitoring is not needed, a strict control is not needed, except in hypertriglyceridemic pancreatitis. This is my last slide. Why I wanted to show this slide is, on the left hand side, this is the very recent score which looked at chronic pancreatitis prognosis score. Why I wanted to highlight this is, you look at the parameters, pain, endocrine, inflammatory marker, malabsorption marker, and platelets. So they are trying to make a score which is encompassing every aspect of chronic pancreatitis. On the right side, it basically shows that pancreatic enzyme insufficiency needs a multidisciplinary approach. Diet, lifestyle changes, adequate pancreatic enzyme supplementation, and strict monitoring for possible complications which I have mentioned. Thank you.
Thank you, sir, for your insights on the topic. We request you to kindly be seated on the dais.
May we have the honor to invite our second speaker of the session, Dr. Utpal Anand, to come up on this dais. Dr. Utpal Anand, Professor and Head of Surgical Gastroenterology at AIIMS Patna, has done research. His topic for discussion today is surgical management of chronic pancreatitis. May I kindly request him to please begin with his speech.
Good evening, respected chairpersons and dear colleagues. Warm greetings from the Department of Surgical Gastroenterology, AIIMS Patna. At the outset, I would like to congratulate Dr. Vijay Shankar and the entire ISG team for arranging such a nice conference. My topic is surgery in chronic pancreatitis. So main indication of surgery in chronic pancreatitis are intractable pain abdomen, and the pathogenesis of pain must be due to some obstructive factors like stones, stricture or inflammatory head mass, which is causing outflow obstruction resulting in intraductal or parenchymal hypertension. Surgery is not much effective in case of neuropathy. Second indications are complications related to chronic pancreatitis like pseudopancreatic cyst. Other less common complications are bile duct obstructions and dural obstruction and sometimes pseudoaneurysm. And third is malignancy or suspicion of malignancy in the pancreatic head on the background of chronic pancreatitis. As we know, chronic pancreatitis is a heterogeneous disease and surgery need to customize according to pathophysiological feature of chronic pancreatitis. So for surgeon's point of view, single most important investigation that is required for this roadmap is contrast enhanced CT scan according to pancreatic head, because it gives us information about the pancreatic head, whether it is bulky or atrophic. If it is bulky, then it is due to inflammatory head mass or malignant mass. Then it gives us pattern of calcification, whether it is a parenchymal scattered calcification or intraductal calcification in form of stones. Then it also gives us idea about splenic vein, portal vein and supramesenteric vein, which often get thrombosed due to chronic inflammatory process of the chronic pancreatitis. When splenic vein is involved, then it may give rise to left-sided portal hypertension, where management is entirely different. And when it involves portal vein and supramesenteric vein, then it may give rise to pictures like the extrahepatic portal vein obstruction in form of portal cavernoma and multiple collectors in the pancreatic head, which causes pancreatic head dissections or escalation almost impossible. Then it also gives us idea about complications like pseudopancreatitis, what is the location, what is the size, what is the thickness, what is the relationship with pancreatic duct, and other complications in form of bile duct obstruction by saying intrahepatic bile duct medial dilatation. And it gives information about the vascular complications like splenic artery pseudoaneurysm or sometimes hepatic artery pseudoaneurysm. Sometimes the CT scan fails to differentiate between the head mass, whether it is inflammatory or malignant. So in this case, surgeons required endoscopic ultrasound guided FNA or core biopsy, which has now got sensitivity and specificity over 90% in experienced hand. PET CT scans sometimes help, and in most of the literature shows that 10 to 15% cases of pancreatic malignancy can be diagnosed, specifically in doubtful cases, can be diagnosed intraoperative by frozen section examination. So this is an important for surgeons. Other important investigations, blood investigation, which helps to differentiate between the inflammatory and malignant head mass are IgG4 for differentiating it from the autoimmune chronic pancreatitis, and very high value of CA99, which may be suggestive of malignant disease. Then getting all this information by CT scans, then we can divide chronic pancreatitis into four pathomorphological type. First is mainly a main duct disease, where main pancreatic duct is dilated usually more than 7 mm. Here pancreas is atrophic, there is no head mass, and duct is studded with packed with stones. And this is classical of the tropical chronic pancreatitis, which at times was most common form of reported chronic pancreatitis from India, particularly South India. But now it is rare, around 3 to 4% from most of the literatures. Second form is inflammatory head mass, dense inflammatory head mass with calcification of pancreatic head with minimal ductal disease. There is maybe patchy parenchymal calcification but no intraductal stone, and this is classical of alcoholic chronic pancreatitis. Third form is a mixture. It means inflammatory head mass and ductal disease, and this is most common form, which is called idiopathic chronic pancreatitis and must have some genetic basis, and this is the most common form reported from the India as well as from the Bihar, around 60 to 70%. And fourth form is small duct disease, where duct diameter is less than 3 millimeter, which may be or may not be associated with pancreatic head mass, and it is called sclerotic form of the chronic pancreatitis. But before going into the surgery, we require a thorough counseling with the patients, because these patients are often alcoholic and smokers, so it requires complete abstinence from the alcohol and smoke. Because whatever extensive surgery you will do, that the pain will continue because of oxidative distress with this alcohol and smoke. Second, these patients are often depressed and occupied, analgesic dependent, and unemployed, sometimes sleep deprived, so require a thorough psychiatric consultation before going into the surgery, and many of the patients may require antidepressant before putting into the surgery for getting good outcome after the surgery. And third, we have had good discussions with the patient about the outcome of the surgery, because unlike gallstone disease, we are not reducing entire pancreas. Pancreas is still in. So there may be relapses, there may be chances of acute pancreatitis in future. There may be focus of pancreatic malignancy in future. So there is, and in 10 to 15% of the cases, pain may not respond after surgery because of neuropathic kind of pain. So we have a clear discussions with the patients about the outcome of the surgery for getting an optimal result. So the aim of surgery is to relieve of pain so that we have low relapse rate, preservation of exocrine and endocrine functions as much as possible, and restoration of quality of life. In order to achieve this aim, we require personalized surgery according to patient's presentation. In fact, it's not a single surgery that is required in all patients, same type of surgery. So, in cases, for example, in cases of tropical chronic pancreatitis, where many ducts are involved and there is no inflammatory head mass and pancreas is atrophied, the main surgery is opening of the pancreatic duct from the tail to head, removal of all the stones, and then drainage of the pancreatic duct with the loop and Y loop of the jejunum. And this surgery is called Partington's Rockley modification of lateral pancreatitis. In this way, we can preserve as much as parenchyma possible, because these patients already have endocrine exocrine insufficiency before it reaches the patient. Second form, as we told, in inflammatory head mass without the disease, the surgery of choice is dural preserving pancreatic head resection, which is called Baker's procedure. In this surgery, we transect pancreas at the level of total vein, then subtotal pancreatic and pancreatic head snake process resection done, leaving a small amount of pancreatic tissue in the C loop of the duodenum by preserving gastroduodenal artery, and then anastomosis is done in head only. There is no need to open pancreatic duct because pancreatic ducts are not diseased. This is called Baker's procedure. And third, which is most common form of chronic pancreatitis, is idiopathic chronic pancreatitis, where there is inflammatory head mass and ducts are directed with the stones. So treatment of choice here is head-coding pancreaticogynostomy, which is called Fraisse procedure. Here we do excavation of pancreatic head and snake process up to the posterior pancreatic capsule, leaving small limb of pancreatic tissue in the C loop of the duodenum. Here the difference is here we do not transect pancreatic neck at the level of the total vein, and here pancreatic duct is also open in order to remove all the structure in the stone, and then it is anastomosed with blue and white loop of the jejunum, and this surgery is called Fraisse surgery. In case of small duct disease, where the duct diameter is less than 3 mm, treatment of choice is very different. The treatment of choice is ISGCON procedure, where we give V-shaped excision of the pancreatic duct in order to increase the pancreatic duct diameter as well as small and smaller pancreatic to drain smaller and second degree pancreatic duct into the main pancreatic duct. When it is associated with the pancreatic weight loss, then we add excavation, and this surgery is called Hamburg's procedure. And in cases of chronic pancreatitis with confirmed malignancy, treatment of choice is pancreaticoginectomy or Whipple's procedure according to the oncological principles. Here, and the last and not the least, the total pancreatectomy and islet auto transplantation. This is in experimental phase, not done in many centers, and mainly indicated in hereditary pancreatitis, where the chances of malignancy is 100%. It may also be recommended in small duct disease and in pediatric populations where pain fibers is not still formed and the results are better. There are many trials regarding which type of surgery is better. So many trials are already mostly shows that all surgeries are same in respect to the outcomes. So we try to customize the surgery according to the patient's presentations and pathomorphological features. Then few words about the which is better endoscopy versus surgery. Now it is clear that endoscopy is only indicated when there is a dominant structure in pancreatic head or stone in pancreatic head which is obstructing pancreatic duct with upstream dilatation. It is not at all indicated in case of inflammatory head mass which act as a pancreatic pacemaker or multiple stones studded in entire pancreatic duct. If you are contemplating endotherapy, in these cases there is chances of the failure, and 50 to 70% of the cases ultimately require surgery, and results of surgery is bad. This is confirmed by many randomized controlled trials, and meta-analysis is available, and long-term results are also available. Around 5 years of results are there, where surgery results are much better. Then this new concept, what is the timing, what should be the timing of surgery, whether it should be early or delayed, like step of approach, first medical management, then endotherapy, then surgery. This concept of pancreatic neuropathy means as the time progresses, this chronic inflammatory cells infiltrate pancreatic nerves, and it causes pancreatic neuropathy in form of hyperfragmentation of nerves, edema, hypertrophy, hyperplasia, which is called pancreatic neuropathy. It causes constant depolarization of the second order neuron going into the spinal cord. And this phenomena is called spinal hypersensitivity and is called global sensitization. This is called inflammatory hyperalgesia or mechanical allodynia, means simple or below stimulus can give rise to exaggerated, and as the time progresses, this may give rise to the central hypersensitization. So idea of early surgery is to halt this process of pancreatic neuropathy by removing pancreatic tissue from the head in early stage. So there was two observational cohort study, and on the basis of this observational study, one randomized control trial was done, which is popularly known as SCAPE trial by Dutch Pancreatic. It is an RCT done in 88 patients, and power is calculated according to HPT score less than 15 points, and follow-up period is 18 months, and patients included were those patients of the chronic pancreatitis which are confirmed diagnosis on CT scans and who required opioid analgesic less than 2 months of duration. Then it is randomized to the two groups. One is directly goes into surgery, and second group first immunotherapy and then followed by the surgery. Follow-up period is 18 months, and also the EGDP pain score relief is much better with in early surgery group rather than the step of procedure, means first immunotherapy then followed by surgery. So what is our data? This is the AIMS partner data 2020-2022. So total of 86 patients of chronic ulcerative pancreatitis were referred to our surgical gastroenterology department for surgery. ICP was 55 patients, and with ICP with social intake with alcohol intake were 29 patients. Hyperparathyroidism was present in 1 patient, and pancreatic division was in 1 patient. These are all scattered in a whole part of the Bihar, the most high density pocket Patna, Sitamarhi, and Muzaffarpur. This pain was presentation in our patient was 100% because these are patients for referred for the surgical treatment. Average durations at the presentation was around 3 years. Most common complication was pseudopancreatic cyst. Although this in our data is showing pseudoaneurysm because it is a referral center, and most of the patients of arterial pseudoaneurysm is referred to our center for angioembolizations by our intervention radiologist team. Then the malignancy, the risk of malignancy is 3.4%. Diabetes at presentation is 37.2%, and steatoria is around 30%. In contrary to fact that it is told that steatoria chances is less in Indian population because of low-fat intake, but we have seen that it is around 30%. Then we have divided it according to the early onset and late onset, and we found that in late onset cases, chances of pseudopancreatic cyst and pseudoaneurysm are more, while in early cases, diabetes and steatoria are more. Then if we divide it with alcohol and non-alcoholic, then most of the alcoholic patients have mostly pseudoaneurysm and pseudopancreatic cyst. The incidence of pseudoaneurysm is almost 100% in case of alcoholic patients. So we have operated 51 cases, all underwent trace procedure, and follow-up period is around 1.5 years, and all have HPT scores less than 15 points. So these are our publications. When I was at IGMS, 129 patients operated patients published in tropical gastroenterology. Then this is the data from the AIMS Patna, where we have compared with South Indian data of the Velu et al. And this was the cases as medical gastroenterologist telling that some antipsychotic medicines are sometimes helps. We have tried it during the COVID period and got good results. And these are the comparative studies from the other group from South India, from the eastern part of India, and almost all our same means idiopathic chronic pancreatitis is around 64 patients. Male was patient more common diabetes in 1/3 of the patient. Steatoria incidence are different in different groups, but malignancy, our cases was 3.5%, while in South Indian population it was very high because it was mainly from the tropical chronic pancreatitis. So according to for future trials required, because most of the study designs are comparison different type of treatment modalities, one endotherapy versus surgery or different type of surgery. So we require improved study design that take into account into various factors like whether it is alcoholic, whether it is smoking, whether it is idiopathic, what is hereditary factors. Then only we can get a conclusive result. Second, all trials aim point is pain. Just 1 second. for all trials, the main objective is the assessment of the pain. But still, there is no standardized and comprehensive and validated approach to pain assessment. Still, we are relying on HPT pain score or visual analog score, which is purely subjective, and it depends upon what is intensity, what is frequency, what is analgesic use, and what is absent of work from the equipment. There is no any objective pain assessment, so these results can be generalized. So, pain specialists, pancreatologists, intervention, endoscopists, and pancreatic surgeons should come together to ensure an appropriate trial so that it could be accepted by everyone. These are the head coding which are done laparoscopically in our center. This can easily be done laparoscopically. This is actual phase procedure. This is stone distribution. This cannot be removed by the endoscopic method, any endoscopic method. And this is the final pictures, which is pancreatic duct is open from entire tail, body, and head of the pancreas. This is the pancreatic open pancreatic duct with removal of entire stone. This is the head of the pancreas hold up. This is the main pancreatic duct and unsnake process up to the posterior pancreatic capsule. This is thin film of pancreatic tissue left, and this is cauterized portion of the duodenum, and the final anastomosis done by rule and by loop of the jejunum. This is the posterior layer, and this is the final layer. Thank you very much for patience.
Thank you, sir, for sharing such deep insights on the topic. Since we are running short of time, we will skip our discussions. We will bind the sessions by requesting our chairperson sitting on the dais to please present the memento of appreciation to our speakers.
May I have the honor to invite our chairpersons for the next session to come up on the dais? Dr. P.K. Jha, Head of Department of Surgery at IJIMS Patna. Dr. Ajit Kumar Sinha, Senior Consultant Gastroenterologist in Patna. Dr. Rajiv Ranjan Sinha, Senior Consultant Gastroenterologist at Curis Hospital in Patna. Dr. Uday Kumar, Consultant Gastroenterologist, Patna.
Now I kindly request our esteemed speaker of the session, Dr. S.K. Sinha, to come up on the dais. Dr. S.K. Sinha is a professor in Department of Gastroenterology at PGIMER, Chandigarh. His topic for discussion is first week management of acute pancreatitis.
Thank you very much for the kind words. I would like to thank first the organizer and Dr. Vijay Shankar in particular to give me opportunity to be part of this conference. For the next, I have been given 15 minutes time, so what I am going to do is to take certain issues and discuss rather than discussing everything, which is almost impossible for the acute pancreatitis. So first, what is the acceptable criteria for diagnosis when patient comes to emergency? So out of two criteria, one is classic pain, classic symptoms, and then either a mileage or lipase or the imaging finding. We don't rely for the diagnosis part mainly on imaging, that is used in selectively, but the mileage lipase is important. The next question is obviously can we use CT or MRI only when the confusion is not solved by mileage lipase, and of the mileage and lipase, which one to be used or both to be used. So the literature is very clear. The pattern of rise of the two is very similar, but lipase tends to remain elevated for slightly longer period of time. And but both the sensitivity as well as specificity, this rarely happens in medical science, but in this situation both are higher for lipase. And in RCT clearly showed that doing two is not better than one, so one should be doing only lipase, and adding a mileage to it adds only to the cost, not the sensitivity or accuracy. The next question is when it should be repeated. It is not to be repeated because it doesn't help in prognostication, it doesn't help in follow-up.
Only situation which we will like to repeat is when it is done too early, that is within few hours, it turns out to be normal or less than threefold rise, then we can repeat possibly between 24 and 48 hours. So that is one. Then the second question arises in emergency room is which analgesic. So we have choices like morphine, pethidine, tramadol, pentazocine. These are the common analgesics which we use. NSAIDs can be used, but that increases the risk of renal toxicity. So generally the persons who are predisposed, we avoid NSAID use, but that can be used, that has efficacy. But out of the narcotics, which one to use? The crux of the issue is what happens to sphincter of eye pressure, and as shown that morphine and pentazocine clearly raise the sphincter of eye pressure, so they are not to be preferred. In contrast, pethidine, tramadol, they don't significantly increase the sphincter of eye pressure, so there is no risk of worsening of pancreatitis. So those are the to be preferred agent, tramadol. Buprenorphine also minimally increases, so those who are fan of buprenorphine, they can continue to use. So we have three choices: buprenorphine, tramadol, or pethidine. So either of any of these can be used. Then which fluid and how much fluid? So conventionally, one thing is very clear, the fluid of choice as of now is ringer lactate. Ringer lactate should be preferred fluid compared to normal saline. So that is the preferred solution. Then how much and when to give, how to give. So that is it. There are three strategies. One is aggressive therapy, aggressive fluid resuscitation, and then we have target-based therapy, target-guided therapy, or we have standard resuscitation. So that one thing is very clear, that crystalloid is preferred, ringer lactate is preferred, but important here is one point, that starch is not to be used. Starch has been shown to increase the complication in randomized controlled trial. So in meta-analysis, the ringer lactate was superior to normal saline and all other fluids, so that is the preferred fluid as of now. So we can use either goal-directed therapy or early aggressive therapy. Early aggressive therapy, when we talk of only 48 hours. Important point to remember, early aggressive therapy doesn't mean therapy going on for 5 days, 7 days, or in the first week. This is only 48 hours, so that's why it is called early aggressive therapy. That involves administration of 200 to 500 ml per hour of isotonic crystalloid solution, unless there is cardiovascular contraindication, elderly patients, or there is renal comorbidity. In those situations, fluid overload will happen, and that is fairly dangerous situation in the setting of acute pancreatitis, so that should be avoided at all possible costs. But currently favored is goal-directed therapy, and goal-directed therapy, what we do target of perfusion. Target perfusion, we check for the target. What we check is heart rate, mean arterial pressure, JBP, and urine output. If you are going for clinical monitoring, but era of clinical monitoring is gone, either it will be lab monitoring or it's the invasive monitoring. So in invasive monitoring, we either check for CBP, we check for pulmonary capillary wedge pressure, IVC diameter, IVC filling indices. So we mostly now rely on IVC diameter and IVC filling indices, which is done in the ICU or ward by the resident doctor. So it doesn't require radiologist per se, but serially we can monitor blood urea nitrogen concentration and hematocrit. The target hematocrit, if the baseline hematocrit was normal, it should be between 35 to 44. But important point to remember, overly aggressive therapy can be detrimental, and it can be detrimental pretty rapidly, so that should be avoided at all costs. And what should be the frequency of monitoring? Possibly 6 hourly monitoring in most situations will be good enough. So then comes the issue of nutrition. So which nutrition is to be done? Whether this is enteral or parenteral. Enteral, then which form? Then we are going to see that. So the idea is to start feeding as early as possible. Mostly that will mean that within 48 hours, even in the setting of severe acute pancreatitis, 80% will be mild pancreatitis, so there definitely we are going to start within 48 hours, maybe within 24 hours. But even in the setting of severe acute pancreatitis, most of the time we are able to start, and enteral nutrition is always preferable. Oral nutrition is preferable to nasogastric. When the patient is not tolerating, only then we will go to nasogastric treatment. And what happens that if we are able to achieve
enteral nutrition, the rate of organ failure, infected pancreatic necrosis and all other complications are less compared to the patients who are given total parenteral nutrition. So there is not much of confusion that most patients of severe acute pancreatitis even should receive enteral nutrition, and most patients will be able to tolerate that. Initially, when a patient is not tolerating fully, it may be point that it will partially supplemented by parenteral nutrition. So this reduces the risk of complication. Of the enteral nutrition, we have three choices. We can go for elemental feeding, we go for polymeric feeding, which is standard rice to feed. Whatever you get, blenderize it, sieve it, and give it through the tube. So that is the best preparation available. Immune enhancing feeds are available, commercially available. They are expensive, and in randomized control trials, they have not shown to improve the outcome. Elemental feed, as you understand, this is pre-digested, where fat is in the form of glycerol and fatty acid. The protein is in the form of amino acids. So that type of feed has very high osmolality, and that has not shown to be better than polymeric formula. So the crux of the issue is polymeric, initially little low fat, rapidly build up. Similarly, the amount initially low and then gradually build up. It can be given either through, if patient tolerates orally fine, if it's given through nasogastric, it can be either given through the feeding pump, continuous feeding, or intermittent bolus feeding. So these are the three ways of giving tube feeding. So any of those can be given, not one is not superior over the other. The biggest issue is when patients are not tolerating orally, then we try to place the tube. Tube, it should be nasogastric or nasojejunal. So RCTs, multiple RCTs available, and verdict is clear that nasojejunal is not better than the nasogastric feeding. So what is summary? The optimal route of feeding is enteral. The optimal timing of feeding is as early as possible. Nasogastric is comparable to nasojejunal. Immunonutrition doesn't add to any efficacy, and probiotics at the moment are not recommended. We will come to that again. So there are multiple trials on probiotic which have not shown clear superiority. So now one of the important issue in the initial part is to determine the severity of the disease, and I told you already that 80% will be mild or moderate and only 20% will be severe. So that is important. So currently, concept level, this is interstitial pancreatitis and necrotizing pancreatitis. Most of the patients who have severe disease are actually derived from the subset of necrotizing pancreatitis, but diagnosing necrotizing pancreatitis requires imaging, either CEMR or contrast enhanced CT scan. So modified Atlanta, which we are following, three types of severity. Mild acute pancreatitis, this tends to improve within 48 hours, 72 hours, and there is no local complication, there is no systemic complication. In moderately severe, there is either local complication, or if there is systemic complication, organ failure, then it tends to improve within 48 hours, then it is moderately severe acute pancreatitis. Severe acute pancreatitis, when there is organ dysfunction, which can be single organ or multiple organ, and which tend to persist more than 48 hours. So what is organ dysfunction? This is defined by modified Marshall scoring system, which is recommended, and this has been shown here. The score of 2 or more will be taken as organ dysfunction, organ failure. Many of us are more comfortable using the previous criteria of organ failure, which was given in original Atlanta classification. That still holds true and works well. So if you are comfortable with this, you are free. There are some points here which are not in the modified Atlanta classification, like GI bleeding is not there at all. Local complication, we divide into less than 4 weeks, more than 4 weeks. What changes in 4 weeks time? So 4 weeks is not the sacrosanct. What is important is the formation of wall. If you are able to do imaging at around 4 weeks, some patients it will be 4 weeks, some patients it can take up to 6 weeks. If there is well-formed wall, then before 4 weeks we call it acute peripancreatic fluid collection, and the same will develop into pseudocyst, and if there is acute necrotic collection, that will develop into worm. So basically what distinguishes between a peripancreatic fluid collection and pseudocyst is wall, what distinction between acute necrotic collection and WAN or walled-off necrosis is the wall. So here you see there is collection, but there is no wall. So this is acute peripancreatic fluid collection. Here you are able to make out the wall very clearly. So this is pseudosis. So similarly, this is acute necrotic collection, and here you are able to see the wall very clearly, mature wall. So that is the walled-off necrosis. And sometimes in infection, the radiologically we cannot diagnose infection barring certain situations. Like in this patient, there is lots of air inside the necrotic collection. So that is clear-cut feature of infected necrosis. So sometimes we are able. Are there alternative methods of defining the severity? Yes, there are lots of scoring systems which we have read over the years, like Ranson's criteria. We have Glasgow criteria, which is dominantly defined for Wollaston pancreatitis, and then we have other criteria. Bishop is most commonly used, and Apache is most useful. So Apache can be serially applied, so that can give you answer whether your patient is improving or not improving. The imaging part, I told you already, 80% patients will not require CT or MRI. Only 20% who don't improve within first 72 hours, they will require further imaging. But one most important part, that when you are not sure about the etiology, or you seem to be apparently dealing with patient of idiopathic pancreatitis, you should go for at least 2 modalities of imaging before labeling it. There is no stone disease. That is very, very important, because that has significant bearing. So CT should always be done beyond 72 hours, because then it gives you decent accuracy. Otherwise, if you done early in the course of the disease, the accuracy will not be that high. So for CT, traditionally we use CT severity index, but we have learned over the years that outcome is not so different between persons having more than 30 to 50% necrosis and more than 50% necrosis. So that group has been merged now, and that has been merged into one. And now we have added extra pancreatic collection, and that is called modified CT severity index, which seems to be more accurate. Antibiotic, if documented infection, there is no controversy, but prophylactic antibiotic has been the point of controversy for long time, more than 15 years, no clear-cut answer. So many trials, but no clear-cut answer. There was trend towards the less complication with antibiotic usage, but no definite benefit in reducing. So as of now, prophylactic antibiotics is not reported in any of the guidelines, except for the Japanese guideline, which recommends in select group of patients the prophylactic antibiotic. So routine use not recommended, and when used, the duration is uncertain. So antibiotics when we use, then which antibiotic we should be using? We talk of efficacy factor, taking into the drug level achievement in pancreas and the culprit agent. And the best one are carbapenems, then ofloxacin, ciprofloxacin, and piperacillin tazobactam. So probiotics are clearly not useful. This is very important slide. So this has to be tackled. Intra-abdominal hypertension, this has been graded 1 to 4. If there is grade 3 and 4, then it is called abdominal compartment syndrome. That is more than 20. It has to be tackled because this has important implication, because with this the outcomes depend seriously. So with abdominal compartment syndrome happens, then the feeding has to be stopped, enteral feeding has to be stopped. There has to be decompression, some decompressive measure in the gut. If there is abdominal collection, the drainage should be done, and that is how it will be managed. And cholecystectomy, age-old teaching that it should be done in same admission as early as possible, as soon as the subsidence of inflammation permits. Otherwise, there is very high risk of the recurrence of pancreatitis. Again, we have come out from the COVID, but COVID has a negative effect on outcome of acute pancreatitis in the form of acute, in the increased severity, increased mortality, and increased prevalence of nephrotoxic pancreatitis. So I will summarize by saying that acute pancreatitis is a disease of unpredictable severity. There is significant mortality and morbidity. Team approach is essential, and stepwise approach is important. And then enteral nutrition is always preferred. Prophylactic antibiotic no role, and radiology has an important role. Thank you.
Thank you, sir. In reducing severity of acute pancreatitis.
very important question. Clearly, urinestatine is available in India, being marketed by the company for the use in acute pancreatitis. Especially searched on this issue, barring the old Japanese guideline. The current Japanese guideline has changed. So the previous version had mentioned urinestatine use, but if you talk of European American guideline, they are absolutely silent, not recommended in any. But in Japanese guideline, the previous version, they have recommended in select group of patients with probable efficacy. So you understand the situation that it doesn't have a definite role, definite benefit evidence is not there. If somebody wants to use based on conviction, one can use. There is one Japanese study which has shown some benefit in selected.
Thank you.
Thank you so much to our speaker. May I have the honor to invite our chairpersons for the last session to come up on the dais? Dr. Ashish Kumar Jha, Assistant Professor, Gastroenterology, IJMS. Dr. Amit Kumar Banka, Senior Consultant Gastroenterologist at Big Apollo Spectra Hospital in Patna. Dr. Saket Kumar, Associate Professor at Department of Surgical Gastroenterology in IJMS Patna. Dr. Vivendu Bhushan, Professor and Head in Department of Emergency Medicine at AIIMS Patna.
I would kindly request our distinguished speaker, Mr. Mahesh K. Goenka, to come up on the dais. Dr.
Thank you, Ashish.
May I call upon the discussion, topic of the discussion? It would be this.
Thank you, Ashish, and the other chairpersons. It's always a pleasure to come back to Patna. This time it's after a gap of about 3 or 4 years because of the COVID. I must tell you a story that my journey to gastroenterology actually started in Indira Gandhi Institute of Patna. And this will be a little surprising that I visited this place for the first time, and the only time before this was in 1986, when the gastroenterology department had just started. Dr. B. N. Tandon, Dr. B. K. Agarwal was here, and I visited the gastroenterology department of this institute and was so impressed by that department. I could see at least about 15 or 18 endoscopes hanging in the Almira, and that's something which attracted me so much that I went back to PGI, and that was my MD days, and I decided that I would do gastroenterology. So actually my journey was stimulated by this institute, and when I was traveling to this institute, I remembered those old days of 1986, almost about 37 years back. So let me come back to the topic, infected pancreatic necrosis. So I'm starting where Dr. Sinha just finished. We are going to talk in about next 15 minutes as to our approach, and this is a slide which you have seen in Dr. Sinha's talk as well, that how we classify the acute pancreatitis fluid collections and how that 4 weeks gap makes it from acute necrotic collection to walled up necrosis. Not necessarily 4 weeks, as he said. Sometimes it may be as early as 3 weeks, and sometimes it may be at 5 weeks that the wall forms. So I'm going to talk only on the right side, which is about necrotizing pancreatitis and how do we treat the necrosis. So this is a picture of one of my patients. On day 4 or 5, this is how it looked like. Necrotizing pancreatitis already there. And you can see that there is a considerable part of the pancreas is necrotic. And after about 5 weeks, you see that this is a collection on CT scan. But if there are youngsters in the hall, I must tell you that CT is not the right way of analyzing the walled up necrosis, because it will not tell you what is the content of the collection. And so either you depend on the EUS, endoscopic ultrasound, or you do an MRI, as is in this case, the same case. You can see now that there is a large amount of necrotic collection which is seen on T1 and T2 images of the MRI. So that is how you evaluate necrosis. So what I'm going to do in the next 15 minutes is to answer 4 questions. 1, when do we intervene in pancreatic necrosis? What's the indications? When do we go early? Do we go late? What's the approach? And the topic was whether we should go for a step-up approach or a one-step approach. And I'm sure some surgeons are still in the hall. So whether it should be surgical, percutaneous or endoscopic approach. And as an endoscopist, we'll talk about a few issues related to the stents of choice. So what are the indications for a classical walled up necrosis? If there is infected necrosis, which is not responding to standard of care. And this has been shown in some studies, including from Orleans Institute, that not all patients with infected necrosis also require intervention. So you may
intervention, when I'm saying endoscopy or surgical intervention, in that study by Pramod, they had used percutaneous drainage in a significant proportion of patients, but as many as 60% did not require endoscopy or surgery. And in the sterile necrosis, we only do it when there is luminal or biliary obstruction or there is persistent pain. So the indications for interventions are very limited. Now, do we intervene early? Now, this is the algorithm which tells us a natural history of pancreatitis. So, look at necrotizing pancreatitis, 153 patients. Acute necrotic collection in 143, 23 expire before 4 weeks are gone. That means even before walled-up necrosis is formed, or if the patient resolves, there is a substantial number of patients which will expire even before 4 weeks. So, do we have intervene even before a walled-up necrosis develops? Now, this is a study, and we were all waiting for the result of the study for quite some time. This is called Pointer study, which was published in NEJM 2 years back, which looked at early versus postponed intervention in necrotizing pancreatitis. So what they did is that early means that within 24 hours of diagnosis of acute necrotic collection, they would interfere, and they will intervene in the form of possibly a percutaneous drainage initially, and the postpone means that you delay as much as you can and only intervene if those conditions which I talked about are fulfilled. So look at the results. This is the immediate results, number of drainage, number of necrosectomy, number of intervention, as compared to postpone. That means 61% only require drainage if you postpone the drainage from the very beginning, 39 without any drainage. Number of necrosectomy is also less in those who are postponed, and number of intervention is less. So this study, which was published last year, Pointer study, clearly showed that you don't need to intervene early. So is there some group where you need to intervene early, that is within 3 to 4 weeks? So the indications for intervention in early acute necrotic collection or in early ward of necrosis where the wall is not very well formed is clinically suspected infected pancreatic necrosis with ongoing organ failure. So if there's an ongoing organ failure, and Dr. Sinha talked about persistent organ failure, then there may be an indication for intervention early before 4 weeks. Organ compression, abdominal compartment syndrome, which was addressed by Dr. Sinha, and occasionally when you diagnose disconnected pancreatic duct in the early stage, but usually disconnected pancreatic duct is diagnosed later. So the first 3 will be the indications for going early. And if you have to go early, this can be again the same 3 approach: percutaneous, endoscopy, and surgery, and I'll touch upon these. But if you look at the indication, and this is Gastroenterology 2020, which says that percutaneous drainage of pancreatic necrosis should be considered in patients which require intervention in the first 2 to 4 weeks. So there possibly percutaneous catheter is preferred over endoscopy or surgery. So we talked about when to intervene. Now the question is one-step procedure or step-up approach. Now if you talk about surgery, and I'm not a surgeon in that sense to talk much about surgery, that the surgery can be either an open surgery or minimally invasive surgery, which can be either laparoscopy or retroperitoneoscopy, so-called VARD procedure. Now, till about 25 years back, and in the early days of my post-DM training, it was open pancreatic necrosectomy, which was associated with significant complication, mortality, and long-term pancreatic insufficiency. And so we have moved away from pancreatic necrosectomy. So this is a trial which was published almost 13 years back. Again, this is named, that was a Pointer trial, and this is Penter trial. This compared single step open necrosectomy compared to step-up surgery, and the step-up meant that you initially do a percutaneous drainage and subsequently go for minimally invasive retroperitoneal necrosectomy. So this was a study again conducted in about 80 odd patients. So these are primary open, where open necrosectomy done, and this is step-up approach. And look at the results. The result says the complication is much less in the step-up approach. The percutaneous drainage alone was sufficient in about 35% of the patients when you went for a step-up approach, and new onset multi-organ failure was again lower in step-up approach. Mortality, there was no significant difference. So this clearly showed, and it showed almost 13 years back, that step-up surgical approach is better than open necrosectomy. At least one decision was taken. Now, this is a study which was published 2 years back. This is actually a Penter trial follow-up. So same patients who survived were followed up for a mean period of 86 months, and to see whether which of the two approach ultimately on a long term was better. And this clearly showed that major complication rate or death was less in step-up approach, exocrine deficiencies was less, and endocrine deficiencies were also less. So this also showed that if you have gone for a step-up approach, your long-term results are better by a step-up surgery than surgical approach than a single surgical approach. Now let me move to the endoscopic step-up approach. And when we talk of endoscopic step-up approach, it means that you are doing an index procedure where you are draining the wall of necrosis, which can be either a metal stent or a plastic stent, and we'll address that a little later. Now if this works, it works. If it does not work, then after a few days you can do declogging of the stent. So here you can see the necrotic material is sitting there, and you just remove this necrotic material. Step 2 is that you pass a catheter into the cavity, a nasocystic catheter, and do a lavage with that. That's a step 2. And final step would be direct endoscopic necrosectomy. So in a step-up approach of endoscopy, you go from index procedures to step 1 to step 2 and step 3. And this is a elegant study published from AIG, from Sandeep Naktakia, which shows that if you are doing an index procedure, you will have a success rate of 74.6%. If you add declogging, it will increase by about 5%. If you do a nasocystic catheter installation and irrigation, then another 5 to 7%, and you require necrosectomy in only less than 15% of the patient. So this is an important study which showed that you require direct endoscopic necrosectomy if you go by a step-up approach in a small number of patients. But that's not the end of the story. There was a subsequent article published, and which showed that early resolution of wall of necrosis with fewer number of necrosectomy was there in direct approach as compared to step approach, and this difference was significant. So the jury is not yet out. So in generally what we practice is that we modify the step-up approach. We don't go for a direct endoscopy necrosectomy. We go in again after 3 to 4 days and then decide whether a direct endoscopy necrosectomy is required or not. So we have modified our step-up approach in view of the data which is available. So till now I talked about when, I talked about approach. Now let me talk about surgery versus endoscopy and what's the role of percutaneous techniques. Now this is an old trial, almost 11 years back. Again, it starts with the name P. It's called Penguin trial. We talked about Panther and Pointer trial. This was on a small number of patients, but was widely quoted because this was the first randomized study which compared endoscopy with surgery, and published in JAMA. And it said that endoscopy necrosectomy was better because it has less complications and better interleukin-6 response, which was shown in this study. So this addressed that whether we should move away from surgery to the endoscopy. And then there are a number of trials which has compared endoscopic step-up approach, which I talked about, one way or other from what Dr. Naktakia mentioned. You may modify that step-up approach, and that's what we do. And surgical step-up approach, which basically means a percutaneous catheterectomy first, and then decide, depending on the wall is formed or not, either laparoscopy or a VAD procedure. So there can be two arms of this trial. And this is what has been done in two studies which have been published in the last 4 years, and they are called Tension trial and the Miser trial. Tension trial was published in Lancet 2018, and Miser trial was published in Gastroenterology in 2019. Both looked at endoscopy versus surgical step-up approach. Mind you, step-up approach. So I have summarized the data of the two studies here. They looked at new onset organ failure, death, complication, pancreatic fistula, and hospital stay. And in one of the study, Miser study Gastroenterology 2019, it was shown that complication rate was much higher for surgical step-up approach compared to the endoscopic step-up approach. And both studies showed that the pancreatic fistula and the hospital stay was better for endoscopic step-up approach compared to surgical approach. So what's a follow-up of these patients? And interestingly, this follow-up of tension study is called extension study, which was published only a few months back in Gastroenterology, which has again looked at the patients who survived from tension study, were enrolled for this extension study, a follow-up of 7 years, and they looked at some of the data, and I have just projected the important ones: major complication or death, pancreatic fistula, and re-intervention. And they found that endoscopy scored over surgery in terms of pancreatic fistula and re-intervention. So this is a very good graphic abstract which is worth looking at, which clearly showed that even a long-term follow-up, possibly endoscopic step-up approach is better than surgical step-up approach. Now, this is a meta-analysis which again looked at the two arms and found that endoscopy approach scored in terms of major organ failure and mortality. I'm not going to the details of this. So we talked about when, approach, the route. Finally, let me talk a little bit about the technique. So we have now moved away for the last 8 to 10 years to EUS approach rather than endoscopic alone approach. I must have done hundreds of WON without EUS, without much of a complication, but EUS gives you a lot of confidence that you are going in the right direction. So it identifies the debris in the collection, it differentiates a collection from a cystic tumor, it allows you to do a procedure even when there is no bulge in the endoscopy site, it avoids intervening blood vessels by using the Dopplers, and has been shown to have lower complications. So what are the stents which are available? We have plastic stents, and usually we used 7 French stents. You can use 10 French as well, but 7 French, 2 stents are usually preferred. And then you have metal stents. We had bifleng stent, which goes by the name of Nagi, our own Nagi. And then we have Spaxus and Axios stent. These are actually lamb stents or lumen opposing stents. So there is a debate, ongoing debate is how good are plastic stents, how good are metal stents. And if you look at the initial data, this is how the plastic stents looks like, and this is how the metal stent looks like. So if you go and I'll just show you 2 of my videos before I go into the debate. This is a video which it is from 2012 from our unit. I'm doing this procedure, and this is 2023. We are doing the procedure. So you can see a slight difference. At both the time we have put the metal stent. The one in the 2012 is a Nagi stent, and after 2 or 3 days we are going ahead, and now we have this very easy technique of hot Axios, which is much easier, much faster procedure, very well controlled. And on the right image you can see the Axios stent being placed in 2023. So ultimately you see the first on the Nagi stent one, I'm entering the lumen after about 2 days or 3 days, lumen of the wall of necrosis, and I'm removing the necrotic tissue. I must tell you that in my earlier days I have used almost all endoscopy devices which are available. Dormia basket, Roth basket, biopsy forceps, but I have concluded that the best instrument to do is polypectomy smear. I think that's the one which gives you the maximum tissue per introduction, and this is what we are doing in this particular case, and now we don't even try any other instruments. Usually you can see that, and on the right side you also see another technique that now when we put a lumen opposing stent, we pass a plastic stent through that, usually a 7 French stent, which keeps the metal stent away from the wall, so the chance of injury to the blood vessels is less. And you can see again that we are entering with a polypectomy snare and trying to remove the necrotic tissue. Now this is what is the end point, whatever the technique you use, or you want to achieve this a number of sessions where you have granulation tissue all around. Now, so what is the debate between lamb stent and the plastic stents? There are a number of randomized controlled trials. We can have this discussion for a long time, but I picked up just 2 of them which were published in GUT 19 and GUT 22. This is from Shyam's group, and this is another very good study. And both of them said that the plastic stents are as good as metal stent, except that the metal stent, the technique is faster than the plastic stent. But this is not what is practiced. What is practiced is mostly that we use metal stent, and I was looking for some data to support that. And I came across this meta-analysis which was published a few months back in Canadian Journal, Journal of Canadian Association of Gastroenterology. This is a meta-analysis, and this looked at, I think, about 7 or 8 studies, and they looked at various parameters, and I just summarized it for you. Overall clinical improvement, much better with metal stent. Number of endoscopy sessions, much better for metal stent. Percutaneous placement, again, advantage of metal stent. Surgical intervention, advantage of metal stent. Mortality, advantage of metal stent. I think this is actually the scenario. Most of the us which are practicing intervention endoscopy would today prefer to use a metal stent over a plastic stent, and I think there are data which is emerging on this, and they showed that the outcomes are much better. So SGI, the Society of GI Endoscopy of India, and we have the ex-president also sitting here, the ex-president. So Dr. Richavan is here. So this SGI guideline was published in Journal of Digestive Endoscopy, which I have the honor of editing, and it said in the statement 9, lumen opposing metal stents or bifrench metal stents are safe and effective in patients with WON. And it went on to say that placement of a coaxial double pigtail stent helps in the procedure. So nowadays, most of us would put a double plastic stent for the purpose which I told you about. So if you have a WON with very low debris, you may still go with the plastic stents, but mostly we are going with WON with high debris with lamb. Only thing we must know is that the 2 lamb which are commonly used, Spaxus and Axios, has a length of 1 centimeter. Spaxus actually has 5 millimeter length. So if the wall thickness is more than 1 centimeter, then you have a difficulty in placing these stents. So there you may have to go for Nagi stent, or you may have to go for plastic stents. Now, is there any technique to improve the results of necrosectomy? We have used in our own unit hydrogen peroxide. There are data with water jet associated assisted necrosectomy, morcitellar device, and more recently endorotor has been introduced by, I think, ovescopy. Now this endorotor, I haven't used it, but it's said to be very useful in helping you in the necrosectomy process, and it's a welcome achievement, I think. Now, lastly, if I have 2 more minutes, I'll talk about percutaneous catheter drainage. I think this cannot be undermined. The importance of percutaneous catheter drainage cannot be undermined. We are all endoscopists, but these are the radiologists mostly who help us in these difficult situations. And this is one of our patients where in the first 3 weeks, the patient was very, very septic, organ failure, 9 French catheter was placed. So you must have either Seldinger technique or the Troker technique, and we always do it CT scan or USG guided. You can find out which route is approachable and what technique to use. Larger the tube, better. Multiple tubes will be better. Saline irrigation has been used. In fact, there is a study from PGI Chandigarh where they've shown that saline irrigation can help in these patients. Aggressive protocol, upsizing additional drainages, and dual modalities can help in improving the results. Now, there can be a step-up approach for percutaneous procedure also, and we have been doing this procedure in our unit. So, after the upstaging of the catheter to 32 French, we introduce a normal endoscope through the sinus tract, as you can see, and you can remove the necrotic tissue even from the peripherally placed WON. So in this case, just like the endoscopic technique, we are going through the sinus tract with a normal standard endoscope, and in one sitting you can see how much of pancreatic tissue can sometimes be removed. We published this in Clinical Endoscopy, the Korean journal. I am aware that All India Institute of Medical Sciences, New Delhi, has done a much larger series of percutaneous endoscopy necroscopy. They called it PEN. Now, what is the advantage of percutaneous drainage versus endotherapy? You can also do endotherapy in the early days, but percutaneous catheter drainage can be done anytime. You don't need to wait for the wall to become mature. It can be done for the peripheral lesions also, even if the patient is unstable. Whereas endotherapy, though it leads to faster resolution, allows solid debris and decreased need of surgery, but require most of the wall should be formed, there is an increased risk of bleeding. So to summarize, I'll go with the statement which says that necrostectomy today, infected pancreatic, necrotizing pancreatitis, evolving interventional strategies from minimally invasive surgery to endoscopic therapy, evidence mounts, but one size may not fit all. So it all depends on your location, what is your expertise, what is the solid component, and what is the wall formation. So if there is a central retrogastric collection, endoscopic, transgastric, or laparoscopic, if there is retrogastric with paracolic gutter extension, then you can go for percutaneous catheter drainage and then step up with VAD, or you may add a combination of technique. Thank you very much. This is my team presently in Apollo Health.
Thank you, sir, for your deep insights on the topic.
And endoscopic training, and with placing of 2 or more than 2 double picture 10 cm plastic, do you think it will change the scenario in the version of comparison between these lamps?
I think this is what is known as multi-gated technique, so that you produce multiple communication between the collection and the stomach. And Shyam has shown in one of his earlier data that it's a very good way. But nobody has compared whether that is better than the standard plastic stent which we talked about, where we put 7 French stent, and nobody has compared with metal stent. I think there may not be big advantage of putting a 10 French stent over a 7 French stent. I don't think that the secretions do not go always through the catheter, through the lumen. It goes around the catheter also. So I'm not sure whether 10 French is going to make any big difference in the process. The answers are not there. I think we will wait for the Dutch group, who are so good in doing studies on this, that they come out with a 7 French versus 10 French, with the single stent versus multiple stent, multi-gated, and whether metal stent is going to be the answer. But my practice today, if the finance is not a limiting factor, I would prefer a metal stent over the plastic stent. The problem with the plastic stent is that you need to go several times. And each time if you need to assess the lumen, the cavity, you need to remove the stent. And then you go in again and then place the stent again. Whereas if you're going with a metal stent, you don't need to remove the stent, you go to the stent, come out, and then again go in. So I find technically it is much easier to go with a metal stent. But you have a point, if the funds are limited, resources are limited, I think 7 French may be another way of doing it. I would never go beyond 10 to 12 French. That would mean about 4 or 5 millimeters.
In continuity, endoscopic step of, when do you decide to go for from stent to NBD and from NBD to DAM?
I think if you look at the initial data from AIG, they have gone every 2 to 3 days. So first day they will put the stent, metal stent. They will go again after 48 to 72 hours to look whether there is a necrosis which is sitting there to declogging, and then every 3rd day. I think actually in practice it is not possible, possibly at least in the private sector, to to let the patients be there for about 2 weeks to decide the step-up approach. So we would usually not go for step-up in that way. My usual policy is that I would put a stent, go in again after 40 to 72 hours, and if I find that there is still necrotic tissue, the patient is still symptomatic, I usually do a direct endoscopic necroscopy after 3 days. So my step-up approach is abbreviating it from the first step to the last step.
Thank you everyone for your honorable presence. With this, we mark the submission of our session related to pancreatobiliary condition. There is the need of the hour to take a break and halt this fruitful and rewarding journey, with the promise to meet soon and remount this beautiful journey of exploration and investigation. Thank you everyone. I would like to kindly remind our eminent guests to please show your presence at the inauguration ceremony and gala night at the Bar Hall, Hotel Chanakya Patna at sharp 7 o'clock. Thank you everyone.